Well, good morning, everyone. Shannon, I've got 8:30 on the clock here. Should we go ahead and get started?
Maybe, yeah, we can go ahead and get started. There's a little less than half of the people registered, but they can just jump on in and we can get started in respect of everyone's time.
All righty. Well, good morning, everyone. I'm Stephanie Seeger, and welcome to the virtual Nurture KC annual meeting addressing maternal mortality, driving data to action. Thank you all for being able to join us today. As I said, I'm Stephanie Seeger. I'm the chair of Nurture KC, and this is the first time we've offered our annual meeting virtually. So I would like to walk you through some general housekeeping for today's meeting. Shannon, if we could go to the next slide. Thank you so much. So all participants will be kept on mute throughout the duration of the presentation. This meeting is being recorded, and active Nurture KC members will be able to access the recording on Nurture KC's website. If you all have questions, please use the chat box in the control panel. All participants will receive an evaluation survey link that will come from Children's Mercy Hospital. Nurses will be able to print their CE certificates after completing the survey, and everyone else will be sent a certificate of attendance. Next slide, please. Oh, thank you so much. This program is jointly provided by Nurture KC and Children's Mercy Kansas City. In order to successfully complete this meeting, participants will register online, participate and attend this meeting in its entirety, complete the post-program electronic evaluation that I mentioned a moment ago. This educational activity will be, or has been awarded 3 nursing contact hours. Children's Mercy is approved with distinction as a provider of nursing and continuing professional development by the Midwest Multi-State Division as an accredited approver by the American Nurse Credentialing Center's Commission of Accreditation. No conflicts of interest have been identified by the planners or presenters for this educational activity. All registered participants received an email this week with an agenda as well as full bios for the presenters. Due to a conflict of interest, Dr. Florio pre-recorded her presentation and is not able to attend the event live. Any questions about her materials will be forwarded both the answers, and they will be posted at a later date. Next slide, please. Next, we will use a poll for approving the minutes from our November 15th legislative meeting. Those of you who are members, these minutes were sent in an email last week. So active members, if you could please take a few seconds to look at the screen and vote yay or nay on the meeting minutes. I'm doing it myself, so make sure we hit submit on that too. All right, Shannon, do we have, should we give about 30 more seconds on that? Okay, perfect. I see the results now and we have approved the minutes. Thank you all, and thank you all in attendance for bearing with us while we do these housekeeping items. So if we can move on to the next slide, please. All right, so the agenda and full bios of each presenter were sent to all of you as registered participants. And now I will turn it over to Tracy Russell, who's our executive director, for a director's report.
Good morning, everybody, and thank you so much for joining us. I'm just going to give a very brief update on what's been going on with the organization since we last met, which was a year ago in May. And I will be quite brief, as I know that everyone's here to listen to the great speakers that we have lined up for you. Next slide, please. So, as all of you know by now, we did rebrand this year and changed our name from Mother and Child Health Coalition to Nurture KC. And this was a decision by our board of directors seeking to be more inclusive of all families that we might serve, as well as having an action word in the name of our organization, as our top priority is to act and have impact within the community. Next slide, please. In addition to that, we also relocated our office this year, and we are now at the Loretto, which is on 39th Street, so very close to KU Hospital. And it's really been a great move for us in a lot of respects, but number one is it's really enabled us to add to what we can do in terms of mission, which I'll get into here in a few minutes. And the Loretto is in one of the Healthy Start zip codes we serve. So it's on the bus line and it's pretty easy access for most of our participants. Next slide, please. So in addition to those changes, we also relaunched the website this year, and we were really trying to serve a couple of audiences with the site. And I know that Shannon has pulled that up for you. We were in a bit of a quandary because we have both kind of that health professional and advocate side, as well as families that we want to reach. So what we have attempted to do with this site is we have both a family portal as well as a community portal for professionals. And it's our hope that we can really convey in the easiest and simplest of terms what we're about. And so I think you'll see a very streamlined website here. We have also worked on adding personal stories and more compelling information to the site as well. And of particular note that I wanted to bring to your attention is we do have a members tab now on here that is available to members of the organization. And currently that houses our legislative information from both the Kansas and Missouri legislative sessions. As we go forward, what we would like to do on this member page is really have that serve as a comprehensive resource page so you could access trainings and latest information, and it will be directed again to both families as well as our community partners too. So would encourage you to go take a look at that. We've also updated Facebook as well as Twitter, and are really working to raise that profile within the community and let people know that we're here. Next slide, please. Okay. Shannon, as you're working to get that up, I'll just go on with, I wanted to talk a little bit about what our efforts have been during COVID-19. We have been expanding what we provide to our families. And I think, you know, one of the great benefits of being a small organization is it really allows us to pivot when necessary to meet the need of the times. And certainly this has been an unprecedented time for us. And so some of the things that we've been able to do, and part of this is due to the new space we're in, is we have partnered with Truman Medical Center, and they have supplied us with fresh produce on a weekly basis over the last several months to give to our Healthy Start families. And as our community health workers visited with their families, this rose as the top need, was just access to food. And so we've been able to do that. We've also given grocery store gift cards to all 237 of the families that we serve. We also served as a COVID-19 testing site as well. So it's been really great that we've been able to continue the work and actually expand what we're doing. And we are currently open again in the physical space, but have had to modify certainly how we conduct business. And as you can see from that picture in the lower left, with Safe Sleep, we continue to provide education around that, but have taken precautions as well. So we will continue to serve as needed and respond to our families as best we can. Next slide, please. So that brings me to today's agenda in terms of wanting to pivot into a space where we think we're most needed. And so one of the new services that we've undertaken this year is we have again partnered with Truman Medical Center to address maternal mortality in particular. So to that end, we have Rachel Blades working with us, who is a community health program nurse, and she is serving our high-risk Healthy Start moms. And Rachel just started, I believe it was in January, so we're still in this initial year, but she is currently serving several moms within the program, and we are excited to see what that impact and what those outcomes are like moving forward. And because this is part of Healthy Start, we will provide this service for the next 5 years or next 4 years, which is the duration of the grant. So Rachel's been a great addition, and we're thrilled to have her. And I know that she's going to have great impact for our families. Okay, next slide, please. Okay, so with that, I would like to introduce our keynote speaker, Salima McNeil. Salima is a reproductive psychotherapist from the Philadelphia area. Her maternal wellness village is part of a citywide initiative to reduce Black maternal mortality. She is also the founder and CEO of Ocean Family Center. And with that, I give you Salima McNeil.
Thank you so much for that introduction. I'm so excited to be here. Today, we will be talking about an initiative that I started in Philadelphia to help reduce Black maternal mortality. But I want to start by taking you all on a short journey with me. Imagine 19-year-old African-American female arriving at a local hospital, pregnant with her first baby, listening to the sounds of the faint chatter in the OR, the hustle and bustle of the movements as they prepare for surgery, the smell of the sterileness in the air, and the atmosphere that didn't feel normal. The gentle feeling of a stroke on her head to ask, "How are you doing?" And she nods in affirmation to say, "I'm okay for now." I am her. Again, my name is Salima McNeil, and I am a survivor of a traumatic birth experience. That experience launched my career into maternal child health and wellness over the last 14 years. I am happy to report that, as you see today, I survived my maternal morbidity, and I'm here, and my son did as well, and he is healthy and 14 years old. The Maternal Wellness Village is a action-oriented task force that functions under Oshun Family Center, which is my nonprofit organization. We decided to come together because we realized that Black maternal mortality is a problem in the city, in the state, and in the country. We are comprised of birth workers from all different walks of life. We are all Black women. We're all passionate about this mission. And we all came together to make sure that in the future, we create a different atmosphere for birthing professionals and birthing people, not only in the city, but around the world eventually. We are therapists, doulas, lactation consultants, holistic healers, infertility warriors, and nurses who all realize the importance of reducing the Black maternal mortality rate. We have so much experience. Not only is it multiple levels of education and life experiences, but combined, we have over 50 years of parenting skills, and we're still trying to get it right. 35 years of lactation support, 25 years of laboring support, and 10 years of mental health support. So I really want to point out 10 years of mental health support. So there's 3 therapists that we have, and in Philadelphia, there's only 3 Black reproductive psychotherapists. And that came about in increasing that number because I was the only one. And I knew that I needed more people who were passionate about this that could provide the same service to help combat perinatal mood and anxiety disorders, which sometimes lead to postpartum fatalities. We're also survivors of traumatic birthing experiences, perinatal mood and anxiety disorders, and a host of other things. And most importantly, most of us are mothers. So we come together on the strength of looking at the beautiful struggle and challenges that it is to bring your human earth side and keep them happy and remotely healthy throughout life. And that's how the Maternal Wellness Village was born. Next slide, please. The why behind our mission is bravely rooted in not only centering the Black birthing experience, but also to help prevent those fatalities in the 4th trimester. So in Philadelphia alone, the maternal mortality rate is 27.4 deaths per 100,000 live births. This is also reviewed by our maternal mortality review board, which is comprised of different doctors, birth professionals, organizations who have stake in maternal health. And we come together to review all of the deaths that occur in maternal mortality throughout the year. Although it is a very heavy task, the people who sit on the review board are committed to really figuring out where we fall short. Black women are twice as likely to die within 1 year of childbirth in Philadelphia. Not to mention that our infant mortality rate is high as well. And so when we look at those rates and realize the comparison to our white counterparts, the starking differences are jarring. And we struggle to understand the reasons behind why Black women are dying at a greater rate. This is a public crisis, and we need help on all ends across the nation to really get behind and focus in on why this is occurring and work diligently to reduce these rates. The number of women who die in childbirth globally has fallen in recent decades, but not in the US. We are one of the most medically advanced countries in the world, but our mortality rate has went up over the years. So nationally, 44 to 47 deaths per 100,000 births, 3 to 4 times higher are Black women to perish than our white counterparts. Any fatality is a problem, and we should understand and figure out reasons, not only raise awareness, but be action oriented into fixing the problem. So the Maternal Wellness Village in Philadelphia, we have not only come together to collaborate with our stakeholders, but we put on events to make sure that we have raised awareness to the level that we can transition into being action oriented. Several of the members of the Maternal Wellness Village have worked with legislators to impact the bills that are sent to the House and the Senate to help save Black bodies, because it is an atrocity that Black women are facing in the medical system. One of my favorite quotes from Dr. Monica McLemore: instead of patronizing Black women and blaming maternal health inequities on Black women, we must seek to understand the role of discrimination. So throughout my presentation today, I will not only present you with the facts, but also give you a bit of my experience as well, because it has fostered so much of the passion and the anger that I have used to fuel into positivity, to be a part of this movement as we continue to do the work to save mamas, especially Black ones. A few years ago, I had to go to the hospital because I was suffering with severe abdominal pain. I have a relatively high tolerance for pain, but when I need to go to the hospital for it, it's really a problem. So my family supported me. My husband took me to the hospital, and I had a nurse in triage ask the question, on a scale of 1 to 10, what is your pain level? And I say, just as calm as I'm talking to you right now, I tell her, I said, it is a 10, and I am in a lot of pain. And she says, okay, go have a seat in the waiting area. We'll get to you when we can. And the look on my face was so shocked because I was in so much pain that I could barely walk. But I walked back out to the waiting area, and 2 hours later, still nobody came to get me. At that point in time, I really just wanted to give up. And I told my husband to take me home and that I was going to sleep it off. And so he made the decision to take me to the next hospital. He said, no, like if you're in pain and you ask to go to the hospital, something is really wrong. So he took me to the next area hospital, and within 2 hours, I was prepped for surgery, going into the OR to get an appendectomy that was this close to bursting. Had I went home to sleep it off because I was discouraged, I didn't feel seen, and I didn't feel heard, and it could have been a much worse issue than it was. And luckily, I got the care that I needed. But when Black women go, Black people go to the hospital, one, sometimes we don't already feel supported because the medical system isn't necessarily something that has been built to support Black people, as we will go through, and I will share some history with you as to how the history of the medical system in America has not always been kind to us. So we not only sometimes go in with those preconceived notions, but also the lived experiences that we've had. Now, I'd like to add that I am a very educated Black woman. I am not underserved. And even when I present in the hospital, that was the response that I get. So I can only imagine somebody who doesn't fully understand what's being said, the terms of informed consent, the treatment that you are entitled to in the hospital, of what their experiences are. Next slide, please. Contributors to maternal health disparities. If I could have made the right side of the screen any bigger to say, listen to Black women, I would have. Because we are the ones dying 3 to 4 times higher than our white counterparts. We are the ones that are working to bring our little humans earthside and don't feel safe at times. Some contributors are systemic oppression, systemic racism, oppression, trauma. Those are the top 3. So when we look at the health system or the education system, pretty much both, as a system and the teachings of our doctors and nurses and so forth, and how your implicit bias and your lack of cultural competence can impede the way you treat someone. Now, we all have them. We all have these ideas in our head of how people are, no matter the color of their skin. It could be just the content of their character. And we make these judgments well before we actually get to know them or their story, which is important. And I think it is really important for white people who hold the majority of the population, especially here in America, to not only do the internal work, and that is more than cultural competency and implicit bias training, but is being intentional about learning anti-racism framework and how that work can really be the change and shift in Black healthcare in America. Trauma is a very big contributor. We have 400 plus years of trauma that Black people have endured. And some may think, without fully understanding the magnitude of their statement, to say, well, aren't we past that? Or shouldn't we just get over that? That would be ideal. We want to get over it too. We want to get past it. We want to be able to live a life where we go outside and run or sit on our couches and play video games in our beautiful Black skin and not be a target. If that was the case, we will be over it, but it's not. And so that cross-generational trauma really does come from generation to generation. The ideas of your family influence how you are. The impact that society has on you influences how you are. So when I say trauma, it's not just racial and gender-based trauma, it's community violence, it's poverty, it's abuse. All of those things really do impact the relationship we have with our medical providers. So if I come to the doctor's office and I am 15 minutes late because I have 4 children that I need to get out for school, I have a job that's really unwilling or creating a hostile work environment about my need to take off to go to the doctors, it does make you second think, is this a necessity? Another contributor is a near miss, which I am, and I'm grateful to be here today. And those contributors are excessive bleeding, high blood pressure, blood clots, and heart disease. One of the main components of the Maternal Wellness Village is partnering with our area hospitals to develop a perinatal wraparound program that will help reduce Black maternal mortality. We are in our beginning phases of our clinical trial and really trying to prove the efficacy behind our program to get future funding to continue this. And not only continue it in our city, in our state, but also across the world. So if we can put more hands on people, especially Black birthing people, to feel supported in those moments, we can help reduce those rates. If you had a doula, if you had a lactation consultant, if you had a therapist, in addition to your midwife or your obstetrician that will follow you through that whole 4th trimester, wouldn't we think that those supports that are often not accessible, they don't have the resources, and they're not racially concordant, so it does not feel that there's relatability on a basic human level of shared experiences as we center Black experiences. Microaggressions and medical assumptions. How do we remedy this? And again, I always point to, especially in the birthing place, listen to Black women. We may not know what's wrong, which is why we come to the medical facilities, but we do fully understand that something is wrong. So saying, you'll be okay, it's not that bad, you're not in as much pain, somebody will get to you soon. All of those things are really dismissive. And we really just want you to take a couple steps back to listen, not only to the symptoms, but to the person. Next slide, please. These are some of the historical changes that has occurred. And I see 1932, I'm not sure what's missing there, but I feel like there's something. No, go back, that's fine. Some of the historical changes in birthing practices across, the last generation or so. Granny midwives, historically, granny midwives were cross-culturally assisted birthing women. As birth became medicalized in the 19th century, they were banned and it became a male-dominated field. We have always, and we as in women, have always for generations birthed in a house, in your bedroom, with your auntie, with your mom, with your cousins and your sisters. There were other kids running around the house. The men were off, doing whatever they wanted to do recreationally. And we were a community-based delivery. Everyone was there for support. And that's the basis of granny midwives. So when they were phased out in the 1900s, and it became more of a government control and male-dominated world, we medicalized birth. And I think now a lot of Black women, especially, are seeking midwifery care because you can have a home birth. And there's a lot of fear-mongering that goes with midwifery and their birth practices outside of the hospital. And those things are detrimental to our health and our wellness. The mistrust in the medical system, which is 1932, shifted over a little bit. The Tuskegee syphilis experiment. If you are a medical provider in any capacity and you are not aware of what that experiment not only is, how long it lasted, which was almost 40 years, the support, the government support that was backing it, then you don't have then you cannot get a clear understanding of why there is trust and mistrust in the medical system with Black members of the Black community and the medical system. And then you have Henrietta Lacks, she was a genius and didn't know that the cells that she was dying from and eventually caused her demise were not only replicated, but genetically throughout the entire world, which is why women, we now get pap smears. We are the ones, she was the one to provide the research from her body, unwillingly. She did not know what was happening. Her family did not know what was happening. Her family did not benefit monetarily from this. But this is how Black women have been treated throughout the medical system. I think on this slide as well, I had the father of gynecology, Dr. Sims. He is praised all over the world, especially in some teachings, but fully understanding that he experimented on enslaved Black women to perfect his craft, to then take it to Eurocentric countries and sedate white women to do the same thing. So these are just a few of the things that impact that trust and mistrust of the medical system with the Black community. In addition, this results in the Black maternal mortality rate being so high. Look at the number for Georgia, 66 out of 100,000 births. Louisiana, 72. As any birth is a tragedy, those numbers are for Black people alone. Next slide, please. Some of the key elements of being trauma-informed and what that practice looks like, I alluded to it a little bit earlier. One of the things that a lot of medical offices can do is get rid of the late policy. I get it, time is money. Nobody wants to be so many patients behind. Go back one slide, please. Time is money. Nobody wants to really be behind several patients on a day. They don't want their day to go longer than it has to be. But if we just sit back and understand the plight of the people that you are seeing, that could do wonders. Maybe you end a little early with another client and you're able to squeeze that person in. That really does speak volumes to you caring about the person and their care, because if they're coming to you, they're coming because they need something. They need an assessment, they need blood work, they need to be cared for, and they're being turned away. I would say treat everyone as if they've been traumatized. Natural disasters, car accidents, house fires, physical, mental, or sexual abuse. You should absolutely ask your clients if it is okay before you touch any area of their body. No matter if you're taking a blood pressure, if you work in women's health, being gentle and guiding your patient through the gynecological process, touching before inserting, letting them know and asking, is it okay? Do you feel comfortable now? I'm going to insert the speculum. Okay, take a deep breath. Some providers are very abrasive and aggressive, and it really does hurt mentally and emotionally when you don't feel like you're being heard by your provider. Check your biases. We all have them. If you woke up this morning, if you are listening to me right now and you're saying, well, not me, I treat everyone the same. I don't see color. Those are all very problematic, because if you don't see my color, you do not see me and you do not see my experiences. I want you to understand that when you see me as a Black woman, that my people have been victimized in the medical system for generations, and I might be a little apprehensive about the care. And I might still do it with a smile, but still knowing that there is a fear behind that. Eliminating blaming language, especially during birth, especially during prenatal care. Oh, this person is non-compliant. They're diabetic and they're not doing everything that they need to do. Their blood pressure is high. They're not doing everything that they need to do. Let's talk about why they're not doing those things. Do they have all the resources that they need? Do they have a support system? How accessible are you to answer their questions? And really look at what we can do together to make sure that those are not the messages that we're giving. Fear-based tactics. As a doula, I was a doula for probably 8 to 10 years, and I've been to over 50 births, and I have heard some really troubling things. And a lot of them are fear-based tactics. If a woman has asserted her desire to say, I don't want an epidural, there is a mild coercion that goes on. If you don't get this, then you're in more stress and your baby's heart rate is falling below the line and we may need to do a C-section. Or your baby will die. Or you will die. And those things make it really hard to conceptualize what's happening, because birth is a mind, body, and soul experience. You can do it. You can change the world one family at a time. So I'd like you to take a look at the key elements. Cultural competence. I'd actually really like to cross that out and put anti-racism. Youth and family collaboration, really working with the family. Trauma competence, trauma sensitivity, just knowing, just have the lens. Everybody has been through something. And we don't want to activate intentionally that fight, flight, or freeze mode that ignites in ourselves when we don't feel safe. Physical and emotional safety and trustworthiness. Really have a conversation with your client. You'll learn something. Next slide, please. One of the tasks of the Maternal Wellness Village in Philadelphia is to plan events for Black Maternal Health Week. We spend all year planning. This was for this year, so I just want to make that clear that these are not events that are coming up. These are events that should have happened, and then we had to pivot due to COVID and make it a web series. So we planned a Black Maternal Health Fair so that all of the birthing people in Philadelphia can have access to Black birthing professionals, because there is proof that racially concordant care really does help increase the client-patient relationship, or what is that, patient-provider relationship. Advocacy Day, we are really big advocates for changing pieces of legislation, especially in PA, that will help increase maternal outcomes and improve them overall. And so the goal was to have an advocacy day where we can inform the community of different pieces of legislation that have been worked on and introduced, and if they're in the House or moving to the Senate, and understanding what all of that means. I am fairly new into the advocacy world the past couple years and really learning the nuances of it all, and it's really important for the community to know as well. We had a Black doula meetup that was virtual, and the advocacy day was virtual as well. And that gave a space for not only aspiring doulas, but seasoned doulas to really have a good conversation about what it looks like for treatment of our clients and treatment of doulas in hospitals, because a lot of providers who don't really understand what doulas do are not very nice to them. We also had an infertility healing circle, because that is a form of trauma as well. And we really wanted to make sure that not only women of color, but that couples were able to have a space where they can talk and decompress about some of those things along their infertility journey that may or may not end in a live birth for their little one. We did not have the community baby shower because we couldn't be in person, and we did have a maternal mortality summit online. 2 of our events are still available because we recorded them. So if anyone is interested in revisiting that to see what it is that we did, you can email me I have a contact slide in a second, but you can email me and just ask if you can have access to the slides. There's no cost, there's no fees associated, and I can send that right to you. Here are some of the local and national resources, such as Midwifery Traditions. Jamina Coleman, who is a part of the Maternal Wellness Village, is an internationally board certified lactation consultant. Selena Washington is one of our colleagues who is now a reproductive psychotherapist. I brought her over to the dark side. The Perinatal Mental Health Alliance for People of Color is a subset of Postpartum Support International, where we work to give scholarships to clinicians of color and birth workers of color to get trained on perinatal mood and anxiety disorders. I am on the board of the Perinatal Mental Health Alliance as the fundraising director. And then Black Mamas Matter Alliance, they are doing a lot of the advocacy work around this, and we have supported one another in these endeavors and really do show the support. Next slide, please. So not only do I want to thank you all for joining in today, but here's my contact information. Here's my email address. Please, if you have any questions about the organization or support or how you can get involved, please feel free to reach out. You can text the phone number that we have here listed. My website just got a facelift and we are now live. So you can go on our website to look at some of the things that we've been able to do, and then follow on Instagram at Oshun Family Center or Maternal Wellness Village, both. This picture right here is really indicative of how women who have given birth that may not have ended in the desired result feel sometimes about their bodies. My body did not fail me. I wanted a vaginal, but I had a C-section, and my baby is healthy, and I made it, and I'm here. One thing that I want to point out before I go is on June 3rd, I launched a fundraiser to raise $5,000 so I can provide psychotherapy to members of the Black community who were impacted by racial trauma. Due to the unjust and unrest that the community was feeling after the deaths of Ahmaud Arbery, Breonna Taylor, and George Floyd, within 30 days, I have raised almost $100,000. And with that, we have been able to provide 8 free therapy sessions for those of the Black community who have been impacted by racial trauma. It has been an amazing ride, and I just want to thank anybody who has already supported and really emphasized the importance of allyship and standing in solidarity with the Black community. There is no way that I would have not only reached, but exceeded my fundraising goal in overabundance and been able to put together and gain the support for the Maternal Wellness Village and my organization, Oshun Family Center, without the help of white people who are standing not only on the sides, but in front and in back to say, you know what, this is a problem. I may not know exactly what to do, but here's how I can support and I will support. And throughout the mission of not only doing therapy, but I really stress the intersection of racism and how it impacts maternal outcomes and what we can do together. We are so much stronger together. The division doesn't have to continue because the momentum right now within this movement, I don't want it to only be a moment. And as we come together and really form a mighty force, we can do all things together. Thank you so much. Please connect with me. And I truly enjoy being here, sharing not only part of my story with you all, but the formation of the Maternal Wellness Village and the very important work that we're doing here in Philadelphia. This next presentation really goes well as a continuation about the health disparities in maternal mortality. So I am actually excited to stick around and really see how in depth the intersection of racism and maternal mortality go and how Dr. Smith is going to lead the way for it. So please, if you have any questions, I think our panel is around, is it 11:30? And so we'll be here to answer all your questions.
Greetings, everyone. I'm so grateful for the opportunity to come to you today to really talk about these maternal mortality disparities and to really talk about what we're doing in the community and how we can all work together to reduce these disparities. Again, my name is Charlotte Smith. I am in the Department of Population Health at the University of Kansas Medical Center now. And I am going to talk to you today about surviving pregnancy, the silent tragedy of maternal mortality disparities. Next slide, please. Today, we're going to really talk a lot about the significance of this work, why it's important to do what we do, why we care, why we should care, why you should care, why the work that we're doing is so important. We're going to talk a little bit about the disparities, the causes, really focus on structural racism and how that's impacting the Black body and maternal mortality. We're going to also talk about the work that we're doing here in Wichita, Kansas, that we'll soon be doing in Wyandotte County as well. And then we're going to talk about the charge. What action could we take to all work together to reduce these disparities? Next slide, please. So what are these disparities? African American women, as we know, are Black women, as I described so much in my work, across the income spectrum and from all walks of life are dying from pregnancy-related complications at 3 to 4 times that of non-Hispanic women in this country. Not only is that starkest, but African-American women in Kansas are dying at 3 times that than non-Hispanic white women. So we have to start to change these racial disparities. Particularly if you're looking at this slide, you can see that in Kansas, the maternal mortality rate is 26.6 per 100,000. The white maternal mortality rate is 22.6 per 100,000, but the Black maternal mortality rate is 69.8 per 100,000. This, I would say, is a public health crisis. This is a pandemic that we haven't found the cure for or the vaccine for. Next slide, please. There are many causes of maternal mortality, but most of these pregnancy-related deaths are caused by cardiovascular disease, which is often found in young pregnancies, but not in Black women. Women around this world are dying of childbirth from many related issues, but mostly from hemorrhaging and preeclampsia, which is increasing the complications. Some of these complications that women are suffering from are obesity and advanced maternal age. The bottom line here, when we look at this data, we can see that there are many causes of pregnancy-related death. But the bottom line is that too many Black women are dying largely of preventable pregnancy-related deaths associated with some of these outcomes. Next slide, please. So when we talk about significance, we have to really look at the fact that there are women across all spectrums, all walks of life that are suffering. Serena Williams, a well-known tennis star who survived many issues such as a blood clot in her lungs. She's bounced back from knee injuries and suffered many racist issues, episodes while playing tennis as a Black female tennis player. She would say that she's one of the most powerful women in the country. However, Serena has her own story that she was not listened to during her birth experience. Serena Williams mentioned that, "I just remember getting up, I couldn't breathe, and I was like, I can't breathe. Like I couldn't take a breath. I told the nurse, I can't breathe, I need a mask. So I put the oxygen mask on and started coughing because I couldn't breathe. It hurt so bad, and then my stitches broke. And I remember I was in the bathroom with my mom just crying and crying. And she was crying too. She was like, you just gotta breathe. And I was like, I can't breathe. So Serena had to basically advocate for herself to receive the quality care that every woman in this country deserves. Next slide, please. Not only does Serena have a story, but Beyonce, who's a world-renowned artist, performs in many settings, and we see her a lot in our lives on a public platform. She had her own story. She said, my health and my baby's health were in danger. So I had an emergency C-section. We spent many weeks in the NICU. I was in survival mode and did not grasp it until months later. Because when you're in survival mode, you're really trying to think of what's best for your body, what's best for yourself, and what's best for your infant. You don't have time to really think a lot about what's happening to you. You're just going through the motions. Next slide. Not only are these stories present, but there are many local stories behind these things. There are many people, many families out there that have some very similar stories, some extreme stories, some not so extreme stories. Behind these statistics that I showed you earlier of the causes of pregnancy-related death, there are stories of individuals and families. And to bring this to the forefront, we must begin to listen to these women. We must begin to collect these stories. We must begin to do the work around those things that are really impacting the women and that are really causing these disparities in maternal mortality. Not only do these local women have stories, but I myself have my own story. Born a preemie at 5 pounds, I didn't have the same birth experience as my mother. My birth experience was what I would call true quality health care. Not knowing that I was a high-risk single Black female of the age of 20, pregnant, my doctor walked me through every step, through being obese or not being obese. I wasn't obese at the time, but he talked to me about nutrition. He encouraged me to exercise daily for a daily walk. He talked me through the birthing experience, any care that I needed, as well as family planning after that. So I had a healthy baby boy in 39 weeks. Of around 7 pounds. However, what I didn't know until years after having that baby boy is that I suffered from postpartum depression. But because there's such a stigma around being weak as a Black woman, and there's a perception that Black women are so strong, no one listened to me. So imagine me, a young adult with a healthy baby boy who doesn't understand why there's a disconnect, why I'm not attaching to my baby, or why I feel so sad. No one listened to my story. So this is really important to me that I really listen to women's stories. Next slide, please. We talk so much about the social determinants of health. And for Black women, the social determinants of health, including income, level of education, and other socioeconomic statuses, is not a protective factor as it is for white women. Social determinants of health that affect the health and quality of life in people is in any given environment where a person lives, earns their living, and plays. One of the main ones that we don't talk about is race. We talk about the different statistics, but we don't talk about how race plays a role in this, or particularly how racism is a part of the parcel of being Black in the United States, how it compromises the health of Black women and their infants, how applying a racial justice lens to contextualize this urgent public health crisis is critical at this moment. Put simply, structural racism compromises our health. So today we're going to really focus on what's happening. Next slide. We often talk about racism using a case definition. Someone's developed a definition and that's how we defined it. But what we need to know is that structural racism restricts access for people of color to health promoting factors. Some of those factors are wealth, income, safe housing, quality education, and healthcare. So we can't begin to reduce these disparities by only looking at the healthcare that these women receive. We have to look at those things in the community that are creating barriers for them. Structural racism in healthcare and social services delivery means that Black women often receive poor quality of care than white women. It means that the denial of care when Black women seek help when enduring pain is not there. It means that some social providers, social services providers, and some healthcare providers fail to treat these women with dignity and respect. So the totality of ways in which society fosters racial discrimination via mutual reinforcement of inequitable systems, that in turn reinforces discriminative beliefs and values and distribution of resources, which means the lesser gets less. Next slide, please. So racism, not race itself, is the driving force behind these disparate high rates of maternal deaths as well as infant deaths. It is the driving force of the higher maternal deaths, and the systemic barriers are fueled by both explicit and implicit bias. And yes, we all have them. But the important thing is, how do we acknowledge that we have them? How do we begin to address them to reduce them so that we can address these disparities? Some of these are following in the lack of quality health facilities and providers, harsh environmental factors, highly concentrated food insecurities within communities of color, and inequalities not only in the community, but within our workplaces. Next slide, please. We know that mothers are monitored less, their concerns are often dismissed, and they tend to be sent home without adequate information about potentially concerning symptoms. For African American mothers, the risk jumps at each stage of labor, delivery, and postpartum process. So what can we do? We've decided, my colleague Dr. Redmond and I decided that we would begin to work in the community with a community initiative. And what we've done is we've developed a community initiative working with the Divine Nine in building a birth equity network. So our first goals was to basically bring this group together. And if you're not aware of what the Divine Nine is, these are Black fraternity and sororities in our communities. And the idea and the concept behind this is that these individuals come from those communities that are impacted by high maternal and infant mortality rates. Therefore, already have trust established within those communities, and they can go about sharing these data, sharing what we should do to reduce these disparities in a better way than we can. So we began to work with them to really look at what can we do to reduce infant mortality initially, and now to reduce maternal mortality. We meet with this group monthly. So we've asked each of these Divine Nine to send a representative to a Saturday meeting for an hour. We strategize on how we as a community can address things. And each year we host an event called Celebrate Day 366. And that event is actually to do two things. One is to change the narrative of us always talking about deaths, to celebrating babies that live past the 365 days. And the other is that we realized when talking with those in the community and doing an assessment that they didn't understand what we were talking about, which means they were not aware of the high infant and maternal mortality rates, and they had never been encouraged about how we could address them. So at that event, we have the sorority, which talks about understanding infant mortality and what it means in your community. The fraternity presents on the importance of co-fathering and fatherhood. And then at the end of that event, we have a birth equity conversation to really dive into what we need to do as an initiative to really create birth equity. So as a part of the next steps of our initiative is to really train these diverse stakeholders to conduct PCOR and comparative effectiveness research and to develop a shared community academic research agenda. But we must do something before doing that. So we have decided to take on a study to really collect Black women's stories in our community. So we designed an instrument that really addresses this from each stage. We've talked, in this instrument, we asked them about prenatal care, we asked them about birth, and we asked them about postpartum, as well as we attempt to identify health birth equity through what they're seeing, what they're experiencing in the community, in the healthcare system, and from their families, and what the fathers are experiencing. Next slide, please. So this is a red cap online survey, and participants were asked to complete a questionnaire consisting of 5 sections: demographics, prenatal, birth, postpartum, and health equity. And again, in health equity, we really asked them about what they were experiencing in the community, not just with social services, but when you go to the grocery store or when you do other things in the community, as well as what were their families experiencing, particularly the father. And then we asked them as a community, how could we better support them during their pregnancy? Next slide, please. So I'm going to talk today about some preliminary results. We have about a 30% response rate, and that's because we seek to get 75 responses, and we have 65, but some of them are partial responses. 69% of the respondents identified as Black. Next slide, please. So while you may not be able to see this, and I understand that, sorry about that, this is actually looking at what were some of the things that were indicated. So in asking questions with the women, we initially asked them about the number of prior pregnancies. And so most of these women had 1 or 2 prior pregnancies. Most of them had 1 or 2 live births. Most of these women started prenatal care in their first trimester. Most of them received group medical practice or solo medical practice during that prenatal care. Most of them participated in prenatal care education programs. Next slide, please. So what did we find in birth? In birth, we really looked at, were there any complications during birth? Most of these women identified high blood pressure, loss of pregnancy or miscarriage, and C-sections. Next slide, please. So when looking at infant outcomes, we really asked them what was the number of live births, whether or not they had 1 or more live births or something else happened. And so most of these women indicated that they had 1 or more live births. And then some indicated other, which we'll discuss more when I start to talk about the themes in qualitative work later. Next slide. So when asking them about post-birth services, most of these women attended nutrition classes, had breastfeeding support, but also indicated that they suffered from postpartum depression. Next slide, please. So what we wanted to do was really take this data of collecting stories. So we used a lot of structured questions, but we also used some open-ended questions, although this was an online survey, and allowed them to fill in different areas to really tell their stories around these things that have happened. And some of the common themes, remember this is very preliminary work as the survey is still active, was satisfaction of care, birth experiences, postpartum depression, and birth equity. So I'm going to talk to you a little bit about percentages as well as the common themes identified and some of the quotes from the women. Next slide, please. So when thinking about satisfaction of care, the survey asked the women, whether they were satisfied with their care, and whether or not anyone ever asked them if they were satisfied with their care or if they required an additional care. And so 32% of the women said they were never asked if they were satisfied with the care that they received. 26% did express satisfaction, and 58% reported positive treatment from their prenatal care doctors, such as respect, professionalism. Next slide, please. However, some women detailed negative responses, not just from physicians, but from staff, such as nurses and receptions. One participant stated, "I heard the doctor not knowing my name." So speaking of me, but asking what was my name. 2 women reported, "I was sent home mistakenly." Both of them stated this. One woman stated, "I felt no enthusiasm from the staff. It was if they didn't like me." And one woman stated, "I waited 3 hours before receiving treatment." We have to do something about these things, because this means that women aren't seeking the treatment that they deserve. And there are so many other factors, as you remember when I talked to you guys about structural racism and social determinants of health. There are so many other factors at play that are not considered. And I understand that medical providers have their limitations as well. But we cannot afford for high-risk women to sit in a waiting room for 3 hours to receive treatment when there are so many other barriers in play to them seeking that care. Next slide, please. For birth experiences for the mothers, 58% reported a complication with their pregnancy. Some of those complications were preeclampsia or sent home by a nurse ignoring the doctor's orders. 37% elaborated on their delivery, saying that they had pain, excruciating pain, fibroids, high blood pressure, and emergency and unwanted C-sections. And that person that talked about that emergency and unwanted C-section really talked about how they were aware at the end of the day that they needed that C-section, that it was required, that it was medically required. However, no one talked to them about what was happening and why it was happening. And they asked their doctor specifically to make sure that they did not have a C-section during their prenatal care treatment. So the issue becomes, why aren't we taking the time to really talk to our moms, which means that in the end, we don't value our mothers and we don't listen to them. 62% of women reported normal and healthy babies. Next slide, please. 2 women lost 1 pregnancy and 1 woman lost 2 pregnancies. One participant stated she and her baby were left in the hallway alone for hours after the delivery. Another woman stated, "I specifically asked my doctor to avoid a C-section." One participant stated, "My baby was born with an enlarged intestine, which I feel should have been seen in many of the sonograms that I had." Next slide, please. Next slide. Thank you. For postpartum, 42% reported postpartum depression, and they described these as anxiety, lack of energy and motivation, loss of identity, and feelings of failure. So our previous speaker talked about how we can feel like our body fails us, but it doesn't. And some of these experiences are within that postpartum period. Next slide, please. One participant stated, "I was never asked about their mental health and being fired while on maternity leave." This participant informed her physician and those around her that she was fired while on maternity leave, as well as the fact that her insurance would have to change, but no one ever asked her about her mental health. One participant stated, "I experienced postpartum after all 5 live births. It was the worst, but with the help of a few people in the community with different community resources, I was able to persevere." Another participant stated, "I stayed in denial most of it. In the Black community, mental health issues are frowned upon. So you stay strong and push through. You're okay. You have to take care of that baby because nobody else is going to do it." A participant stated, "I had postpartum anxiety. It was never addressed by my OB. I sought therapy to work through it on my own." Next slide, please. When asked about birth equity, really about what we can do as a community to better support Black women during their pregnancy, participants stated listening and meeting patients' needs, more information about prenatal and postnatal, including fathers in the care, which we should normally be doing, but this is something that we leave out constantly, is what is happening with the fathers. And so that's one of the reasons why we wanted to include this in the study, is because no one has asked how the fathers feel or how the fathers were treated. And also professional counseling. Next slide, please. So in birth equity, one participant stated the community should listen and take time to ask questions and provide resources. So there's that word listen again. Someone's not listening. Another participant stated, stop judging based on racist scientific medicine. Believe our pain and concerns. Had my pregnancy OBGYN didn't judge me, he wouldn't assume, and I quote, that I was a big girl, strong girl. I thought you'd be able to pop him out with no problem, is what I was told. Your statutes say it should have been no time. And then sometimes bad things happen to good people. Here's a reason to address biases. Another participant stated, let moms and dads know more about prenatal and postnatal knowledge. Another participant stated, support the people that support us. Stop using them to recruit us. This participant went on to talk about how in the Black community, it often feels like those that have community services and resources that actually help Black women are often utilized to recruit them for research studies in which they are still not listened to or cared for. Next slide, please. So in this study, some of the preliminary conclusions are this preliminary understanding of the experiences of Black women in Sedgwick County, Kansas. Also that it's evident that there are gaps in the care of Black women. It is evident that Black moms and dads experience racism in the healthcare system and in the community in which they live, work, and play. It is important that we know the experiences of women to create birth equity. We talk about birth equity often, but how do we create this birth equity without knowing what these women are experiencing in their community? And not just when they're pregnant, but when they give birth and what happens after pregnancy and how are they treated within the community. So not looking at equality that each person gets the same thing, but looking at equity when those who need more get what they need, even if some gets less. Next slide, please. So when we think about action, we think about what should we do to address these issues? And there are many things that we can do. The textbook answer would tell you to improve access to critical services, improve the quality of care provided to pregnant Black women, enhance support for families before and after birth, offer Black women tools to navigate the health setting, and offer Black women the tools to navigate the community. But I want to challenge you today to begin to dismantle these systems that create barriers for women of color. Let's begin the systems work. Real change will require greater knowledge of why Black women and infants are more likely to die as a result of pregnancy-related complications and birth. Real change will require greater knowledge of what we can do as a collective to do this work. So what can you do? Embrace the concept of community of action. Let's all come together and do the work, and let's make sure that we know that each person has a seat at the table. Each person plays a role. How can we strengthen that? The other thing is focus on systemic racism and structural racism. How do we begin to reduce these issues? How do we acknowledge that this has happened? How do we heal our community? So some of our work will have to be on using the healing justice framework to begin to heal from racism so that we can begin to really reduce these disparities, to look at weathering of the Black body and how is that related to these birth outcomes. Think of birth equity not only as a process, but as an outcome. How can we measure it? How do we measure birth equity as a collective, and how do we begin to increase this around the country, not just in Kansas, where there are a lot of Black women suffering, but nationally where Black women are suffering. And they're 3 to 4 times more likely to die as from pregnancy-related complications than any other race. We've got to begin to address this. If we want to collaborate, we must begin to have open communication, shared goals, such as what we see presented here, and allow everyone to have a part at the table. Next slide, please. So some of our future work is going to focus on continuing to do this work in the manner in which we begin to really look at what Black women are experiencing. And one of the things that we want to do, or that I'm planning to do, is to really look at how do we begin to collect Black women's stories about family planning. What are some of the discussions that they're having with their physicians, with social services, as they begin to plan their pregnancy? Some of those conversations that they're having at work as they begin to plan their pregnancy. So what's happening prior to pregnancy that can also be addressed and to reduce these disparities. We want to work collaboratively and train our community members, but also be open to being trained by our community. We don't know what our community is experiencing often, and oftentimes they have to train us as we are the ones trying to do the work, but in a collaborative manner. We're not knowledgeable of everything. So we have to have that open mind to allow the community to train us while we're training the community. We want to design a 5-year research plan in collaboration with these diverse stakeholders and Black moms and dads. So having everyone at the table to really try to address this issue, to really listen to those voices. And there are going to be some difficult times, because there are some people that are very passionate about this work. As our previous presenter talked about, there's a lot of trauma. And there's a reason to really look at how we're going to heal these communities. But one of those ways is to really have a safe platform where we're listening to these women, which means they're not judged, they're not cut off, and we understand their passion, their concerns, and the trauma that they've suffered. We want to continue to listen to Black moms and dads. No matter what we do, we need to continue those conversations, and we need to continue to listen to them so that we understand that the things that are really impacting their pregnancy. But not just moms, but let's listen to fathers as well. Fathers should be acknowledged. Next slide, please. I'm so grateful for this opportunity to share my passion, the work that we're doing, and to be on the platform with many individuals who care about these disparities and who are working hard to do them. Let's dismantle these racist systems together. Let's really dismantle these systems that create barriers for women of color. Thank you so much.
Okay, hello everyone. Coming to you straight from my bedroom since I can't be there on Friday. I'm Karen Florio. I'm one of the maternal fetal medicine specialists at St. Luke's, and I'm here to talk to you today. Well, I'm here on Tuesday, and you'll be seeing this on Friday. To talk to you about caring for the cardiac patient in pregnancy. Specifically, I want to talk about the congenital cardiac patient. So I have nothing to disclose and no conflicts of interest. Today, we're going to talk about a really cool case presentation, which is going to lead us into the discussion of the disease states of cardiac disease in pregnancy, current risk stratification models that you should be aware of, antepartum and intrapartum management, which is going to be short because we really don't have any recommendations yet, and then obviously, I can't take questions, but I'll give you my email at the end, and if you have questions, you can email me. So this is the real patient. This was my patient. She's a 21-year-old G2P1 at 11 weeks who was brought into our cardiovascular ICU status post-arrest twice. She had a history of 1 full-term vaginal delivery and was now currently 11 weeks by her report. And the only other history that she had was knee arthroscopy. So the story goes is that she was at work and told a coworker that she felt kind of funny. Young girl had chest pain, so didn't really think much of it, but felt lightheaded. Her coworker, coincidentally, was a nurse in a cardiac unit and told her to call her doctor. However, the patient became unresponsive and several coworkers actually found her down in the break room. No CPR was initially performed. However, emergency services were so close by that they got there immediately. CPR was immediately started, and doses of epinephrine and 4 shocks were administered. The patient was found to be in defib at that time. So on arrival to the emergency department, her blood pressure was stable. Her heart rate was slightly up at 106. Her temperature was 95. She was placed on a cooling protocol the minute she got there. Her respiratory rate was 20. Glucose was 135. Her original oxygen sat during that episode was 18%. And CT showed diffuse bilateral infiltrates with a negative urine drug screen. She was immediately intubated and sedated. She appeared at the time to be posturing, so they thought maybe it was possible seizure etiology. Again, this is a young patient who went all of a sudden into cardiac arrest with no underlying disease state, so Ativan was administered. Due to the episode of cardiac arrest from unknown etiology, the decision was made to transfer her to a tertiary care center. So upon arrival at the tertiary care center, she was found to be in pulseless electrical activity. She did regain her pulse rapidly after 1 milligram of epinephrine. So this is the 3rd time now that she's received epi, and more chest compressions. She was transferred to the tertiary care ICU. She was found, a bedside ultrasound was done, and she was found to have a 11-week fetus, but unfortunately the fetus had passed away. So the diagnosis was recurrent ventricular tachycardia with unknown etiology in a 21-year-old patient with no history of cardiovascular disease, 11 weeks pregnant now with fetal demise. So the plan originally was due to an inability to oxygenate her, they put her on VV ECMO. She was started on broad spectrum antibiotics, again, because nobody knew what the etiology was. A respiratory panel and cultures were obtained. MFM was consulted. This was in the middle of the night, so I ended up showing up at 4:30 in the morning. Continue on cooling protocol, amiodarone drip, and she was started on ionotropic support. So the differential at the time was an amniotic fluid embolism, which would be really rare in an 11-weeker unless you were instrumented. Pulmonary embolism, which is common, malignant arrhythmia, which she clearly had, myocardial infarction, sepsis, or acute giant cell myocarditis. So a bedside echo was done, and it showed abnormal wall motion with global hypokinesis with an EF of 30%, normal wall thickness, so no chronic disease state, a normal aorta, normal right size and function, no clot in the PA trunk. And this was done by our CV intensivist and was later repeated by one of the cardiologists. So she had ECMO cannula placed, and she did sustain another event at that time of VTAC and defib arrest and required defibrillation. Repeat echo was done, and she showed significantly worsening function with 10% EF. So MFM was consulted for an emergent D&C, and at the time that wasn't really her biggest issue, but we came to see her. Due to her unstable situation, we felt that it was not appropriate. Her coags were up and it looked like she was in DIC, so we thought it better not to go in and instrument her. She did receive blood and her coags normalized. She did pass some tissue overnight, and a morning ultrasound still revealed retained products, so we thought it would be better to give her a site attack. So 400 was placed per vagina times 3, but 4 days later, she still had retained products, so we did a bedside D&C in the ICU. So over the next couple of days, she was continued on ECMO support with vasopressors and ionotropes. Again, remember, we have no idea what happened to this patient. Started on steroids for presumed myocarditis. Repeat TEE was done on hospital day 4, and it looked like that original event to the myocardium. It did recover to about 50%, and she had normal RV function. And I put this in here specifically because we need to pay attention to that part. On hospital day 7, ECMO was discontinued, and she was extubated on hospital day 8. A cardiac MR was performed on hospital day 11 that showed an EF that recovered to 68% without any other notable structural abnormalities. So she had multiple imaging modalities. On hospital day 14, she underwent placement of an ICD. At the time, the running diagnosis was long QT syndrome, and she was discharged home on amiodarone and nadolol to follow up in the heart clinic. So we saw her as an outpatient in MFM in our cardio obstetrics clinic 6 months later and counseled her about future pregnancy risks. She did get a Marina placed at that time. 1 year after her original incident, she was seen by electrophysiologists and worked up and underwent an accessory pathway ablation. Her diagnosis was then changed to Wolff-Parkinson-White. She came back to us 1.5 years later, so we have a lot of history with this patient. After an initial event desiring pregnancy, we discussed the need to follow up with cardiology, and she needed device interrogation, and then we would discuss taking her IUD out. With that sneaky little gal, she went someplace else, got her IUD out, and showed up 6 months later, pregnant at 8 weeks to establish care. So our plan was to follow her every trimester with echoes. She was enrolled in one of our studies that would image her every trimester. We were going to see her every 2 weeks, and then every trimester she would be seen in our cardio obstetrics clinic. Genetic counseling was done because, again, we thought it was Wolff-Parkinson-White or long QT, and those things are familial and they have significant association with inheritance for the baby. And so later on, we were going to decide on where she would deliver as far as whether it was going to be in the ICU or on the labor suite. When, so whether we needed to take the baby early or if she could go all the way to 39 weeks, and whether she required a cesarean delivery or not. So at her second trimester echo, we got a call from the echo lab that the patient actually had undiagnosed Epstein's anomaly. So if you remember correctly, she underwent at least 3 echoes while she was inpatient with her initial event and a cardiac MR. And Epstein's was missed on every single one of those imaging modalities. She had lived her entire 21 years of her life without ever knowing that she had this. She had normal LV function and no right ventricular dysfunction. So to make a long story short, she went on to deliver at 38 and 3 with a scheduled induction on labor and delivery, had a successful vaginal delivery, and was discharged on postpartum day 3. So let's talk about how we care for somebody like this. So for those of you who know, I am like a physiology nut. I always start all of my lectures with physiology because if you don't know pregnancy physiology, then you cannot take care of a pregnant patient. And so it's really important to understand the changes that are going on so you can understand what's going on with the patient on a broader scale. So this is one of my favorite pictograms of the changes of the cardiovascular physiology in pregnancy. What you can see here is the 4 images showing both multiparous patients and prime patients. So the multip patients are the open squares and the primes are the closed squares. And you can see that there's a change in end diastolic volume, change in stroke volume, you have a change in systemic vascular resistance and a change in cardiac output. You can see all of these things change significantly in pregnancy. So your cardiac output increases, starts in the first trimester, increases all the way to the 3rd trimester by about 40%. And then when you're in labor, which we're going to talk about a little bit more, goes up another 40%. So this is all to increase the uterine blood flow and therefore to oxygenate the fetus at term. The blood volume by default, venous desensibility also increased. So your blood volume increases by 50%, and that volume has to go somewhere. So your desensibility increases so it can kind of hide, if you will, within the venous system. The maternal heart rate increases by about 20 beats per minute. And there is a concomitant decrease in systemic vascular resistance, again, like we talked about. So your blood pressure goes down in the mid-trimester, and your pulmonary vascular resistance also decreases. There is also a decrease in the colon-oncotic pressure, and that's why pregnant women tend to get very fluid, I don't want to say fluid overloaded, but puffy. So they get swollen. So let's talk about some of the anatomic alterations. So the ventricular wall mass actually thickens starting in the first trimester, and your end diastolic volume also increases. Again, that volume's got to go somewhere. So the heart actually accommodates by getting a little bit, the chamber's getting a little bit bigger. This increases the cardiac compliance from softening of collagen without a reduction in the ejection fraction. And that softening of the collagen is actually really important because pregnant women are at increased risk for spontaneous coronary artery dissection, for dissection of the aorta, because that intima of the vessels is much softer in pregnancy. Your myocardial contractility increases, you have remodeling of the intimal lining, the internal dimensions of all the cardiac chambers increase, as we had mentioned. There is slight regurgitation in all of the valves, but should not be in the aortic valve. And there is an increase in the cross-sectional area of the left ventricular outflow tract. So I used to carry this around with me as a fellow, so I could remember all of the changes that occur in a pregnant patient, so that if I were to ever need to go take care of somebody who was in the ICU or was critical, I could remember these changes. So that was antepartum. What about intrapartum? So during the intrapartum time period, the physiology continues to change. And so in the first stage of labor, and for those of you who don't remember, the first stage of labor is once you start laboring all the way up to 10 centimeters. And so there's another 30% rise in the cardiac output. You can imagine your body is working really hard, and so your heart is going to start working really hard. And a lot of this is due to stroke volume. So if you remember that the equation for cardiac output is heart rate times stroke volume. And so most of this increase at that time is due to stroke volume. In the second stage of labor, when the patient's pushing, you get another 50% increase. So by the time all is said and done, from baseline to the baby's out, there's going to be an increase in cardiac output of about 80%. Sorry about that. Let me restart that. Okay, back to what we were talking about. Okay, so you get this rise in the second half of labor of your cardiac output. You can cut the sympathetic outflow and decrease that cardiac output by a little bit, but it's still going to be, again, a rise of about 80% over baseline. Remember, if you think of the uterus and the placenta like a sponge. So if the uterus contracts and you squeeze all the fluid out of the sponge, you have about 500 cc's of blood going back into the intravascular volume every minute the person contracts. So you squeeze, the fluid goes into the intravascular volume, then the uterus relaxes and that fluid comes back into the placenta. So that's a continuous fluid process that happens throughout the labor stages. Blood pressures increase throughout pregnancy, or sorry, throughout labor, obviously because of pain and the like. So no joke, this is actually what I look like. Not her, this, after I had my kid, and we can all relate, right? So what about postpartum? So people kind of think that after the baby's out, you're all free and clear and we're done, right? Actually, this is one of the most tenuous times for a pregnant patient, especially with cardiac disease, because of all the dynamic fluid shifts. So immediately postpartum, you have an 80% increase in cardiac output because, again, think of that sponge. Now you've contracted the uterus down, so all the blood is out of the uterus, and the placenta is out. So you have that low flow state that had about 500 cc's just sitting within it out of the body. So all of that goes back into the patient's vascular space. Remember also that you have this like 30-pound massive child with fluid and placenta that now comes off the cable vessel. So all the fluid from the lower extremities is now free to come back to the heart. You have that auto transfusion that we talked about, and you have rapid mobilization of extravascular fluid. You have a 60% increase in your stroke volume, and sometimes you may see a reflex bradycardia in these patients. All of this results in venous return to the heart, which increases your cardiac output. So this occurs within, like I said, 10 minutes and goes back to pre-labor values within an hour. But some of the changes that we had talked about up until this point can persist for up to 6 months postpartum. So for those of you who have ever seen the CMQCC or some of the literature on cardiac disease in pregnancy, I thought this was a really great slide on how to differentiate common signs and symptoms of normal pregnancy versus those that are abnormal. I think it's really hard sometimes for people to differentiate the symptoms of heart failure versus routine pregnancy symptoms, because every pregnant patient has dyspnea, right? So how can you tell dyspnea of heart failure versus dyspnea of normal pregnancy? Or one of my favorite things that the cardiologists talk about in our cardio obstetrics clinic is they'll always ask the patient, how much salt do you eat? Or are you swollen? And it's like, oh, she's pregnant. She's always swollen, right? So how do you tell? I thought this was a really great graphical representation of how to do that. And the red, the green, and the yellow kind of to give you like a warning when you're hitting that red, what you should be aware of and alert your team to. So again, just one last taking it home picture on the changes, the cardiovascular changes that occur during pregnancy in the first, second, third trimester. We talked about the differentiation between stage 1 and stage 2 of labor, what happens postpartum, and again, these changes can persist for up to 6 months. So now that we've gotten through all of med school in 15 minutes, let's talk about congenital cardiac disease. So what I think is really interesting is that with the advent of cardiovascular surgery, more and more women who are born with congenital cardiac disease are surviving till adulthood and desiring fertility. And so more women with corrected, both corrected and uncorrected, and that does happen still, congenital defects are surviving into adulthood. In fact, I have a patient right now who is a little Honduran lady who didn't know that she had L transposition until she was 15 years old, and it was never corrected. So she's currently in my practice. So the uncorrecteds are still out there. Adults now represent 2/3 of all people with congenital cardiac disease. So it's not the children anymore, there's more adults with it. It affects 6.1 per 1,000 adults, and 60% of those are women. So we're gonna be seeing these patients in our practice guaranteed. So what we need is management strategies to take care of these women. So I think it's challenging because, one, we don't have really good prospective data to guide our management strategies. And so we rely on European data, and we know that the Europeans are thinner, they're healthier, and they're having babies at younger ages than we are now in America. And our obesity rate is much higher than those women that were included in these studies. So it's really hard to generalize these to us. However, it's what we have, and so that's what we use. So I kind of broke it down by neonatal and maternal outcomes. And now I'm going to talk about several registries and risk stratification models that came out of those registries that we use now to risk stratify people when they come to our offices. So CARPREG was done in like 2001, I believe, came out of Toronto. There's a really great cardiology group up there who evaluated women with mostly congenital cardiac disease. I do believe there was 11 women with acquired disease, and looked at risk factors that predicted outcomes. And what they found was they had a 20% adverse neonatal outcome rate, and 16% of their women with congenital cardiac disease had cardiac complications. Most of those were heart failure and arrhythmias, and we'll get into that. The ROPAC data is about 6,000 women out of 30 countries in Europe, and found a 0.6% neonatal mortality rate, which is higher than what they have there, and a 1.7% fetal mortality rate. For maternal mortality, they found 1%. Now you think 1% is not that big of a deal, but the general population is much lower than that. And then the Zahara risk calculator, or the risk assessment, found that there was a higher rates of miscarriage, preterm birth, smaller gestational age fetuses, and higher neonatal mortality. Again, what the both prior two studies have found. Zahara didn't look at an increase in obstetrical adverse outcomes, but did find an increase in cardiac adverse outcomes. So again, heart failure and arrhythmia are the two big ones. And we're going to talk about all of these in a little more detail. So CARPREG 1, like I said, was out of Toronto in 2001. And what they found was they had 4 endpoints that predicted outcome. And each one of these, if you had one of these, you gained a point on the risk model. So if you had a history of a prior cardiac event, that's 1 point. New York Heart Class Association, functional class greater than 2, or cyanosis, another point. Left heart obstruction or left ventricular ejection fraction of less than 0.4, that got you a point. And so with that, they looked at, okay, so you have these points. What does that mean? So these are risk predictors. And with those risk predictors, you can estimate adverse outcome. However, what I want you to pay attention to here is that there is a wide variation in number here. So if you have no predictors and you have underlying congenital cardiac disease, you have a 5% risk of having some kind of adverse outcome. If you had more than 2, you had a 75% chance. So again, this is older data coming out of Toronto, and we needed better risk predicting models because, again, this was mostly congenital patients, not acquired patients. So how do you counsel a patient who has a heart attack, right? Really great for congenital, not that great for acquired diseases. Again, this is just showing the number of predictors. So again, if you have more than 1 and what the predicted outcome would be. Again, a really high rate of adverse outcomes. And this just kind of breaks it down by the type of congenital disease. You can see there's all kinds. Our Epstein's girl is in here somewhere. There she is right there. She wasn't actually in it, but they did have Epstein's patients. And again, I had mentioned ischemic disease, there was only 11 patients in that study. So good amount of data, about 250 patients with congenital cardiac disease to develop this risk stratification model. And this is CARPREG-1. So 4 predictors to look at outcome, just cardiac outcome in women with congenital cardiac disease. So then comes along CARPREG-2. So it was since 2001, that group got together again and added on to the data. So they actually used the older data, but then tagged on more patients. So here is the epoch of 1994 through 2000, and then they looked forward from 2001 to 2014 and looked at the change in the incidence of cardiac events over time. So was there a difference in, I mean, you could say care, was there a difference in outcome in those women in the earlier epochs than the later epochs? And they found that they were pretty similar, aside from the fact that maybe it looked like cardiac deaths went down. However, I will tell you that they excluded anybody who had a pregnancy under 20 weeks, and a couple of those women died. So a little bit of an inclusion bias and less pulmonary edema. So what they found was that 73% of all pregnancies with cardiac disease had at least 1 cardiac event. I mean, think about that. We have a very large population of women out there desiring fertility with either congenital disease or acquired, and 2/3 of them will have some kind of adverse outcome. So we really need to be aware of what to look for and how to risk stratify these women so we know when to get them to a tertiary care center when we're taking care of them when they're pregnant. So the most common lesions or most common outcomes were arrhythmia and heart failure, and you can see them stratified by the weeks of gestation here. Again, the incidence of adverse cardiac events during pregnancy, now they have a population of over 1,900, which is really great. Looking at the outcomes, again, similar type of graph for CARPREG-2, but now they've added on to the risk stratification model. So we have more predictors, as you can see here, and a better predictive model. I really liked this flow chart at the end of the CARPREG-2 paper, just kind of illustrating what they went through to develop these risk predictor models. So they took a patient history, they looked at their history of cardiac disease, they looked at any echoes, they looked for signs of cyanosis. They stratified them by specific lesions, which is really important, right? Because an L transposition that's uncorrected will act very different than a corrected BSD. They looked at delivery of care, which I think is a really important predictor because the care that you receive in Kansas City might be very different than the care you receive in Oklahoma City, depending on what kinds of providers you have there and what's their training. So really quickly, just to go over the Zahara risk calculator, this is really handy because you can just Google it if you have a patient in your office, and you can put it up on the calculator just like a trial of labor calculator, check off the boxes, and we'll spit out a risk score for you, which is really handy. So the Zahara study looked at over 1,800 patients with 1,300 pregnancies. All of these patients had congenital disease. So again, a really good predictive model for anybody with underlying congenital disease. They looked at maternal cardiac outcomes, neonatal outcomes. I think those are both really important because mom wants to know what's going to happen to baby, right? And obstetric outcomes. And we kind of already talked about that and what they found in the first slide. So what we actually use now and what most institutions that have combined cardio obstetric clinics use is the modified WHO risk stratification model. And I really like this because it breaks it down by specific cardiac lesion, gives you the WHO class, and gives you a range. So instead of just saying, okay, your risk is 5% when you have, 2 points on your car preg, 0 actually, but this kind of gives you a range. So you can counsel the patient like, we don't really know, but it may be that because you have a corrected VSD, you have a 2 to 5% chance of having an arrhythmia during pregnancy because of all the cardiovascular physiologic changes that occur. So I really like this model. I like to give a patient more of a abstract idea versus absolute numbers. So again, what we talked about, the things that I like about this is that it shows you the specific cardiac lesion here, the range, and where she should receive her care. So really handy. You can Google this and get this online as well. Also gives you follow-up. I forgot to mention that. So what you should do with the patient afterwards. So this is just a nice representation of one study that looked at not only the cardiac disease, because nobody comes billed with just one disease state, right? Hypertension always comes with diabetes. Lupus always comes with hypertension. So I like this because they looked at the comorbidities with cardiac disease and then looked at outcome. I have a little guy who keeps coming in here wanting me to come downstairs, so I apologize. Okay, so just to continue, just showing you with comorbidities who has a higher rate of having an adverse outcome. And you can clearly see that anybody who has underlying arrhythmias, other cardiovascular diseases, and pulmonary problems have the highest rate of adverse outcomes. In the same study, again, just breaking it down by CHD, no CHD, and their adverse events. So you can see here that there's a higher rate of preeclampsia in these women, higher rates of hemorrhage, preterm birth, not really significant, but if you look at the outcomes for heart failure and arrhythmia, if you take anything out of this lecture, remember the 2 highest risks for people with heart disease in pregnancy are arrhythmia and heart failure. Interestingly enough, those are the highest risk for people who also have preeclampsia later in life. So again, this article just shows, higher rates of cardiovascular events, higher rates of obstetric events, higher rates of adverse neonatal outcomes. So we went through all the risk stratification models. You know how to risk stratify somebody, but now how do you take care of them? I think it's really important that we as obstetricians, that we as cardiologists, that we as congenital cardiologists, we come out of our silos of care and we really develop a multidisciplinary way to take care of these patients, because you can't do it alone. Like I could never take care of a cardiac patient without the help of my cardiology colleagues. So we've developed a stratum of how to care for the patient across the continuum of the pregnancy and into the postpartum time period, because we know that that's really a time where adverse events can occur. And so we involve MFM, genetics. So for people who have things like long QT, WPW, obviously cardiology is involved. We involve our interventional radiologists or our cardiac MR docs. Obviously, we have to let labor and delivery know. So we have strong stakeholders in our nurses. We're very lucky that we have a cardiovascular intensive care unit where our patients can go and recover, and we really rely on them to make sure that they're safe in the postpartum period from a fluid standpoint. In the event that we have a patient that requires a higher level of OR, we have a cardiovascular operating room that we can go to in the event that we need a cardiovascular surgeon. So just kind of represent how the team comes together to take the best care of the patient. We also have checklists. So we all know that checklists are becoming a part of medicine. And so I think it's really important if you have a joint program to systematically go about how you're going to take care of this patient. You know, the questions that we always ask is when, where, how, right? When is the patient going to deliver? Early, at term. Where? Does she need CV care? Does she need to be on labor and delivery? How? Does this patient need to have a silent second stage where we actually pull the kid out from below because she can't Valsalva? Or is this somebody who actually requires a cesarean delivery? So this is a great paper by Diana Wolf that was published, I believe, early last year that has this checklist within it. Again, it's from the same paper, kind of stratifies the patient by their symptoms, their vital signs, their risk factors. So I'm not going to go through this. You guys can have these slides and you can take a look at that on your own. So now we've got her to the point where she's going to deliver. Is a vaginal delivery safe? So I went to the Cardiac Problems in Pregnancy conference in 2018 in Italy. And as I was sitting in the crowd, listening to patients or to the lecturers talk about, oh yeah, she can have vaginal delivery. Oh yeah, she can have vaginal delivery. And I'm thinking to myself, well, where does that data come from? Truly, there's not a whole lot of data on that until recently. In last year, 2 publications came out about vaginal delivery and with cardiac disease. And essentially, just to sum it up, these women can have a vaginal delivery. Now, some of them cannot Valsalva, so you have to pay attention to that, but vaginal delivery is safe. It has an easier recovery, less blood loss, and they don't risk the massive blood pressure shifts that you would with a cesarean delivery. So that's just kind of showing, this is just summing up what we had just talked about. So remember, in the postpartum period, you have a significant auto transfusion. So be aware of that. We recover a lot of our cardiac patients in the CVICU, even if we do their delivery on labor and delivery, because again, that auto transfusion happens immediately. It causes a massive shock to the heart because you have this immense amount of preload coming back to the heart, and the heart just got done running a marathon. So remember that in the postpartum period. Plan to see them sooner in the office, sooner than 6 weeks. We generally see our patients within 2 weeks, and again at 4 weeks, and again at 6 weeks. And don't forget to start the discussion of contraception early. These patients really need to optimize their pre-pregnancy status before they become pregnant. It's always a difficult conversation when you have a patient come to you and they have a WHO class 4 status, and you have to start talking about things like termination because the mortality rate becomes really high. So really important to talk to these patients about, get on a form of birth control. Let's optimize your cardiac status. If you want to have a future pregnancy, we absolutely can try, but let's fix what's going on with the heart first. So in summary, and we went through that really fast, it's so important with these patients to assemble a multidisciplinary team. We as clinicians cannot do this alone. We need the support of all of our colleagues around us in their specialties to take care of these women. Establish a plan early. Again, the when, the where, and the how. Utilize risk stratification models for your counseling. See if you can get that patient a vaginal delivery, even if it means she needs forceps or a vacuum, to kind of cut that sympathetic outflow and decrease the risks that are associated with Valsalva. And remember, long-acting contraceptives are acceptable in these patients, and we should really be counseling them before they leave the hospital. So I hope that you enjoyed this lecture. I'm sorry that it is so short. I would have loved to lecture you for like another hour. If you have any questions, my email is kflorio, that's KFLORIO, at stlukeskc.org. Thank you for listening, and I hope you enjoyed.
I'm just checking to see if Dr. Johnson is on yet, because
I am.
you're on. Okay, you are up, and thank you so much for joining us.
I am just gonna move away from my window because all of a sudden my lawn is being mowed, and of course that'd be the perfect time. All right, well, hello guys. I small introduction. Hello, are you able to hear me okay?
We are.
Okay, so my name is Dr. Tracy Johnson. I am an OBGYN for the last 10 years and just entered into maternal fetal medicine fellowship here in July. I have the pleasure of being able to serve people that are actually discussing their topics of interest today at the MHA's LAN, which is just a coalition of people working to improve the quality of care to moms and infants in Missouri at the state level. And then also I have the honor of serving on the perinatal associated mortality review committee out of Just City, so that we can find out what's hurting our moms in Missouri. So I just thought I'd title the talk that we were going to do today, Are We Our Sister's Keeper? Because what I find in a lot of the information that we're learning about maternal mortality in our state is that it really does take this out of mind, out of body look at the medical system in general, and that while something may not be good for one person, it might actually be good for another person or a group of people altogether. Okay, let's see. How am I going to move forward? Okay, perfect. So the objectives of the study are, I'm sorry, not the study, of our talk are to review a little bit of the terminology and then also just talk about social determinants of health in general. We'll look a little bit at the Missouri data and the proven successes, but then I know Allison Otto is going to give a very detailed look at what we found in our recent report put out for 2017 data. So I won't go into that too much, but then also a little bit of hope for the future. Next slide. So when we look at maternal mortality in general, it's very interesting because maternal mortality events internationally are kind of a litmus test for how you're doing with overall health of your country, your state, or whatever group or demographic you're looking at. So if you look at our numbers, in Germany, they're 26th. My son actually plays soccer at a high level, and so we've had the pleasure of going over and playing in some international things he was invited to. And I'll tell you what, it's clean. They're very, very regimented, as you can imagine, and healthcare is a right. They're not having to beg for healthcare. And so their rates are very low, 7 per 100,000 births. Maternal mortality rate in Germany. Japan, who has a lot of different algorithms that they use, are very evidence-based with their research protocols, and they have a rate of 5 per 100,000 births. And then in the US, where we have autonomy to do whatever we want and where healthcare isn't a right, our rate is 17 per 100,000 births, and we're 55th, and we're tied with like Uzbekistan and lots of other places that have a very difficult time getting access to different things for their population. When we talk a little bit about the relationship, I think the font is off on that picture. That what we should make sure we underscore is our terminology, and that pregnancy associated maternal mortality is related to everything that the mom passed away from within a year postpartum. And so it means that it might not had anything to do with pregnancy, but she did pass away during that time. And so we should look at it. Things like this are going to be, she was swimming and she drowned. That would be an accident that is pregnancy associated, that if she weren't pregnant, she still would have drowned if that situation would have occurred the exact same way. But because she was pregnant, we want to make sure we capture that and we look at that in a detailed fashion. Pregnancy related is the thing that's very hot right now, and that is what is directly attributable to pregnancy, meaning did it worsen because of pregnancy, or did the underlying comorbidity make pregnancy worse, which made her pass away? And that's going to be a year grossly. We look at that at the PAMR committee, but at the CDC and WHO level, they only look up to 42 days postpartum. I think it's prudent to make this point because in Missouri, we have elected to look at the 1 year data, and that is because, you know, data is interesting like that. If you look at 42 days and cut it off, we know that cardiomyopathy, as Dr. Florio just discussed, actually shows you that they pass away sometimes 60 days out, or sometimes it's 3 months out with substance use disorder, as we'll see. So for that reason, we want to make sure that we capture the year and really look at, from a public health standpoint, the entire. Next slide. I always use this whenever I'm talking about social determinants of health, and that's because we have to kind of start at the bare bones and foundation of what we're discussing. Social determinants of health are conditions in which we're born, we live, we work, and we age that play a huge role in shaping outcomes. So I'm sure if you think about patients or clients that you've taken care of, you can pick out 9 of these easily that whether they were able to have a better outcome or than another person. For example, if you have a patient that's diabetic and she has gestational diabetes and you diagnose her and you tell her, you know, oh yeah, standard of care is to get a glucometer and to get your test strips, and I want you to test first thing in the morning. I want you to get a fasting blood sugar. It should be less than 95. Then I want you to eat a meal. These are the types of meals and foods that I want you to eat. I want you to stay away from carbonated sweet dishes that have empty calories in them. And then 1 to 2 hours later, depending on what your protocol is, I want you to check your blood sugar, write it down on a piece of paper. And then I want you to do that 4 times a day. You can appreciate that if your children are hungry in the food category, if your children are hungry, and I even say your children because that's a lot of times what mothers are thinking about. If your children are hungry, you are not thinking about a glucometer. You are not thinking about checking your blood sugar. You are not thinking about how you take your insulin that morning because you didn't eat. And I gave you strict instructions that after you eat, take your first bite, you're supposed to take your Humalog. And so if you didn't eat, how are you're probably not going to take your Humalog. And if you only have non-diabetic foods, your blood sugars are going to always be out. That's just one social determinant of health. We can talk about higher education. We can talk about just overall stress. We know that stress is playing a large role in how hypertensive disorders present and manifest themselves. We also can talk about provider availability, which we'll hit on a little bit here in Missouri. For the focus of this talk, since I've done it a couple of times with different groups, I felt like we should talk a little bit about economic stability, education, and economic stability, basically, as it relates to medical care in the medical system, education of the provider as well as the patient, and then the healthcare system in general with governmental implementation of different protocols and systems. Next slide. So when we talk a little bit about today, when we talk about how it relates to Missouri, I thought we'd hit on maybe 6 different keywords. 1 is the medical system in general, 2, the patient provider, and then governmental regulation, dealing with insurance, mental health, and a couple of other things. So in general, with the medical system, we saw in 2017, when we looked at our deaths, we had 60 deaths in Missouri related to maternal mortality where the patient was pregnant or within 1 year of being pregnant. 27% of those pregnancies associated deaths, meaning they happened to be pregnant when they passed, were related, had comorbid conditions dealing with mental health, depression, anxiety, PTSD. That does include substance use disorder. And 16% of pregnancy-related deaths had comorbid conditions of mental health conditions. That's going to be a patient who passes away at the hands of homicide related to domestic violence and had a comorbid condition of severe depression or anxiety. Also, patients that happen to be in, MVAs related to, meth or opioid use disorder. So our medical system is failing at this. We are not doing a good job of capturing patients. We are not doing a good job of identifying them and then treating them. We're really getting better at documentation. We've kind of caught on to the EMR, and we're really all about documenting, especially in the COVID era, because we want to make sure we're billing. In the COVID era, we lost a lot of money because we weren't patients in the same way. So what's interesting is that we're documenting better, but it doesn't mean anything. We might document that a patient has anxiety, depression, history of a substance use disorder, maybe even 6 months ago, but then it doesn't go anywhere. We just put it in the chart so that we can remember to ask her next time, but we didn't really do anything with it. As far as the patient and the provider are concerned, we know that we did not do a great job across the state of standardizing our communication and our protocols. We are now an AIM state as of April. We now have access to all of those bundles. There are hypertensive bundles, there are postpartum hemorrhage bundles, there are prevention of the first C-section bundles, and everything in between. But it's hard to get that to the providers. It's hard to get it to the urban clients, the hospitals here that teach our residents and our next generation of professionals. But then it's also difficult to get it to the rural areas and the areas in the middle part of Missouri where the Mennonite patients are and where the Amish patients are. It's also difficult to get them in St. Louis. And you can be in Florissant, St. Louis, and still have a difficult time getting to the hospital because that area in and of itself has a lower SES and patients that don't have access to transportation. As it relates to just protocols, we know that in 2017, with just injury and education of the patient, were a number of accidents of all types. That might be MVA where you're unrestrained, that might be overdose of a medication, that might be intoxication with alcohol that related to your MVA or just intoxication. And 54% of those deaths that were pregnancy related were just from MVAs where the patients were unrestrained, just a seatbelt. And having that information that we talked about in meetings regularly, we say, how many times do I talk to patients about seatbelts? Once at the new OB, and maybe again when I know they're going to go on a long driving trip. We don't talk about it regularly. So that's on the patient and the provider to make sure that we're doing those simple public health things that can help save lives. And then governmental regulation. With healthcare reform in particular, we're having a difficult time getting access to people because of the way that our laws are formulated. Next slide. So with the medical system, it is broken. If we just take this example of this young lady, she's 25 years old, she's female, she's never been pregnant, she doesn't have any allergies, she doesn't really have any medical problems, and she just has her regular Missouri unhealthy eating, sedentary lifestyle, not because she's lazy, but because she's working, and she's pregnant. Now, in Missouri, we know that between 2014 and 2018, a quarter of our Missouri moms did not start prenatal care until 14 weeks. Now, that's a problem. That's a big problem because now she's got something that's undiagnosed, bad asthma that she thought was always allergies, or, a rare congenital condition that Dr. Florio just discussed. She's not going to figure it out or even seek care, or I shouldn't say seek, even access care until after the second trimester has begun. We know that in African-American women, 40% entered into their prenatal care at 14 weeks. And in Kansas City, for some patients, it was 50%. For Latino patients, it was 56%, largely due to discrimination regarding their primary language. That's really, really bad. I don't know what happened to this slide, but I am going to, I think the font is off. I'm gonna pull up my other one so I can tell you. Sorry, 1 second. Let me pull up my other side. Something happened with the font there. So what's interesting is that mental health in particular contributed to 27% of pregnancy-related deaths. And that in and of itself is a big deal, as we discussed before. Because, if we're not even addressing it with screening questionnaires or access to specialists in the field, then that is playing a role in whether the patients postpartum and third trimester are getting their needs met. And we did see that that was related to maternal mortality in Missouri. With specialized care in particular, we know that 68% of high-risk births were performed at level facilities between 2014 and 2018. How is that a big deal? And this patient, if she starts to have bleeding at 16 to 18 weeks, she has intercourse, she has some bleeding, it's a little bit heavy. She entered into care late, so her dating's a little bit off. And then we diagnosed her with a complete previa at 24 weeks, which is where the placenta is covering the cervix. And that patient, if she lives in an area where she doesn't have access to a tertiary care center, not only does she not have as adequate access to blood, which is increased chances she'll need that, but also her baby, which will likely be delivered preterm, if not very preterm, does have a decreased risk of survival out of the NICU, and also survival out of the LDR, depending on how preterm they are. You can see that these small changes could impact overall the number of mortality and morbidity that we're seeing in our patient population. Next slide. Let's see. Go back to where you are. Okay, so in particular, when we hone in on the patient and provider educational opportunities, there are some opportunities with quality of care, like I talked about with the AIM. There were gaps in knowledge 16% of the time when we looked at 2017 data, and there was a failure to assess or transfer a patient 15% of the time as well. Those are big numbers, I think, when it's just the fact that the provider did not refer on to the appropriate specialist. That's a big deal, because if that would have happened, there was a lot of preventability with patients that had severe headaches, or patients that had repeat visits to the ER for shortness of breath and for pulmonary edema and things like that. That played a role in about 0.25% of preventability, just referring a patient to the appropriate specialist and then performing the correct evaluation. We discussed a little bit about patient education with accidents, where 70% of pregnancy associates were due to accidents, and half of those were MVAs. Also with homicide, the education of the provider that when domestic violence is at play, we need to ask a little bit more questions about whether there's guns around, whether there have been threats made on her life or someone else's life. We need to make sure that 17% of the time, those deaths were due to homicide, and the provider knew that the person was at risk. And we just kind of hope that everything's okay, cross our fingers. That's just unacceptable. And then lastly, with adherence, the patient is told that this is an option for treatment. If they're not able to do it, we need to ask why. We need to stop saying in the chart, sorry, I get a little passionate about this, but we need to stop saying in the chart that the patient's non-compliant. We need to stop back and ask, you know what, I recommended that you take this medication. And, it's so funny. Mama Hakima, who is probably on here, she says all the time, we tell patients to take a pill, but maybe they don't like pills. Maybe there's a cultural barrier to pills. Maybe there's a different way to do something. And so for that reason, we need to ask, why is it that you're not able to adhere to what our standard of care says? Is there something else we can do to bridge the gap with you? Is there a way that I can maybe do a telehealth visit? Is there something I can do that is more in line with your way of taking care of yourself, that rather than to just push mainstream modern American medicine on you, because we saw that patients were prescribed medications and they didn't take them, and we never asked. Then their hypertension was bad, then their diabetes was bad, then their mental health disorders were untreated. It just doesn't make any sense. Next stop. And we said that we signed up to first do no harm, but I think in that we thought that meant do it my way, and I just don't think that is helpful. With governmental regulation, I wanted to take a second and just talk a little bit about the history, because I feel very strongly that if you don't know where you've been, you don't know where you're going. And I say that because prenatal care and women in this country have come a long way in many, many different ways. If we look at the silent generation, women could not access contraception. The first birth control pill was put on the market in 1970. In the 1970s, these women were 25 years old. 40% of white women worked. Half of Black women worked, and they worked at very nominal jobs. And working was considered 8 to hours a week. So if you look at the slide on the left, this silent generation, 40% of them are working, and it's only about 8 to 12 hours a week. They may be teachers, they may be doing some jobs. There's lots of different things that they're doing. Then there's the generation. This is the generation that, they kicked behind. They just took names. And this is classically the women's liberation movement. This is the first generation to overtake men in completion of college degrees. Think about that for a second. The silent generation, the boomer generation, in one generation, all of a sudden they're in the workforce. This is where Rosie, who's got the Rosie the Riveter, and all these coming into looking at that generation, and then they're saying, you know what, my mom worked and she said that I should work and I should get a degree. So they're starting to go to college. We're sending women to college. We're sending them to medical school and law school. And in the 90s, they're about 35 years old. So they surged into the workforce as young adults. And this started to shape a lot of our FMLA laws came into play around now. Maternity leave and, dependent care started to come into our laws. And then you've got the millennial generation now. I feel a little bit older for those of you who know me personally, but I am technically a millennial because I am 41 years old. So this is me. And there's this push for college education, especially if you're at an ethnic minority or 1 or 2 generations away from being an immigrant. And so we are told that we have to go to college. This is our only way out. And there's mounting debt with less accrued wealth, especially in the African American and Latino communities. And then the housing crisis hit. So now you've got debt, you've got a degree, and no job waiting for you. Because of Sex in the City and everything we know about college, there's access to contraception, and there's ACAs coming up and different sorts of insurance plans. So now we're starting to delay our families from 21 to 26. With silent generation, the average time to start your family was 21 years old, which is just an interesting idea. And then the millennial generation is 26 years old. That's a big gap in just 2 generations. Unless you're lower socioeconomic status, which just put a plug in, they have less access to contraception. So they actually still don't have as much of an opportunity to delay their families starting if they want to. Next slide. So after we talk a little bit about that, then we can move into how the governmental regulation is playing a role in maternal mortality. So if you look at this picture, this is a nice little interracial family. Aren't they so cute? And you've got grandpa on the right, who's a version of Peach. Maybe he's Latino, maybe he's white. If he's white, 92% of the time in his generation when he was young, he was working. He was the breadwinner. He was the person who provided for his family, and he did a great job. And then he passed those tenets on to his son, who now he's a millennial, so 83% of the time he's working. Now, sister girl here, her mother worked about 40% of the time in her generation, and her husband worked too, because as an African American family, they had to, if they both work, they have the same outcome and wealth as a single income household who is Caucasian. So in the older generation, both African Americans had to work. In the younger generation, in the for the Caucasian family, only one has to work to have the same equality as the African American family. So Mama, or Medea is what we would call her, she passes on to her daughter, you better get it. You better go to college and you better work. So 78% of the time she's working now, but this is our family unit, right? So that bridges us to now, next slide. You'll look and see that this is why this plays a big deal. We have to go back to go forward, because now with our current state law, these people are working. Back in the day, the women weren't working as much as they were, and they had a little bit of time. If they were teachers, they had summers off, they had some time afterwards during the holidays, and so they could have kids. Now everybody's working, and in Missouri in particular, there's no requirement to have unpaid leave for your appointments, or for your specialist visits, or your detailed ultrasound because you have a complication. There's only half of the private sector doctors are even, workers are even eligible for FMLA in Missouri. I mean, just sit with that for a second. Half. And even those that are, they use it too often, they lose their jobs. So how does this come into play postpartum? We know that postpartum is the window into and the transition into well care. It is truly the 4th trimester. So we diagnose something in pregnancy because we know that you have this asthma or heart condition or hypertension or an autoimmune disorder. Now we've got you under control. You've got your diabetes under control because now we've diagnosed it. Then we boot you once the kid's out, because all we really care about is the kid, right? It's all we really care about. So now we boot you after it's done, and then we drop you. You've got no paid leave. You've got no way to be fully employed with your family. And then in the postpartum income, less than 1/3 of white women are paid for their maternity leave, even when they have decent or good benefits, quote unquote. They're less than 20% of Black women are paid for maternity leave. And so now when I just diagnosed you with something and you need follow-up, not only did I kick you off your insurance if you have Medicaid, but now you have to work. So you can't come to your appointment. Your baby's at home with somebody, God knows who. Hopefully it's someone that your family that you trust. But now there's no opportunity for continuity of care because you just had your baby and all you were was a gestational carrier. That's all we treated you as. You protected this kid. You love this kid. Now the kid's out. We don't really need you to do anything anymore. This plays a huge role with hypertensive disorders of pregnancy, as I'm sure Dr. Florio addressed. Cardiomyopathy in particular, 60% of those deaths are postpartum. So how can you come back in when you're at work and you don't have insurance and you don't have a way? How can I have you get your echo or even pick up your hypertension medications that keep you well when I just booted you? These are our regulatory laws and statutes that keep this going, keep this trend going. When we talk about cardiovascular disease and stroke, 50% of those deaths are postpartum. Preeclampsia and eclampsia, 50% of those deaths are postpartum. Just postpartum hemorrhage in general, 50% are postpartum. But we booted you, kids out. We don't care. Next slide. So, next slide. I think I talked about this already. So when we talk about ways to help the medical system in general, we're looking at use of telehealth for mental health disorders so that you don't have to pick up and leave. Maybe there's even an opportunity to have people do it after hours at a time convenient for the patient. Fear domestic violence. There's all sorts of new ways that people are coming up with that address the patient is safe or not. I'll put it on here. Dr. Melissa Tapey is one of my closest friends out in St. Louis, and she has this revolutionary way of making sure that a patient is safe. And I'll put it on here because I know Sam Collinson is on here. We are going to start doing this. If the patient is coming in for her prenatal care appointment, or she is in triage and she's leaving her urine sample, you have a red marker and a black marker. And with the black marker, you write on there, if you feel safe, write your name in a black marker. If you feel threatened or fear your life or feel like you don't trust your housing situation, whatever sentence you want to use, please write your name in a red marker so that we can address this with you by sometime during your stay. And I think that that is absolutely brilliant. She just told me about it the other day. And what better way than to feel like a patient is not able to tell you? They can just tell you in a discreet way every single time. Different markers. Brilliant, Dr. Tapey. Also, treating substance use disorders as chronic illnesses. You know, you may know about the EPIC program, which is a grant-funded program where you can pick up the phone at most places in Missouri and you can have someone meet with the patient wherever they are if they have a substance use disorder, in particular an opioid use disorder, and they can be put into care with an advocate. They can they can talk to somebody about starting on Suboxone if that's okay. So people are looking at bridging the gap between substance use disorders and treating it as a chronic illness. Next slide. I talked a little bit about AIM bundles. Missouri is an AIM state, so we just implemented the hypertensive bundle and then COVID hit. So we're trying to get that going again where we are reaching more hospital and office systems so that we can all do the same thing and make sure that when we all use appropriate protocols for patients, at least try to do it, then outcomes are better. We know this with CMQCC. CMQCC and California are very diverse patient population, and we saw that even with their diverse patient population, it did work. So it's independent of demographic, SES, or insurance status that those bundles work. Also, having the appropriate evaluation and transfer to a tertiary care center for high-risk conditions, even if it's just a telehealth consult. If you could pick up the phone and phone a doc, a place that knows how to take care of a patient, help you stabilize that patient and get them to where they go, wouldn't that be wonderful if we had that all set up in Missouri where you could pick up the phone and go, I got a lady here, she is sick, I need you to help me. And we could just be on the phone, telehealth going, yep, do this, do that, do this, do that. Wouldn't that be better rather than for us to all be in our silos? There are all sorts of educational forums around the state. There's a grant-funded program, which you may know of, which is Missouri Echo. That happens every, I want to say Tuesday. Don't quote me on the day, but where people get on and they talk about COVID in Missouri. They talk about hypertension in Missouri. They talk about infant suicide death. They talk about infant mortality in general, all sorts of things to just get on. And you can log on to Mizzou and look up Echo and make sure that you are logging into that because they're talking about the whole state and data from there and educating people, and it doesn't matter what walk of life or what type of practitioner you are. Also, there will be a push for to educate patients about MVA and seatbelt safety because we did see that that was one of our #1 causes of death, and that's just senseless. There's no reason for that. Next slide. And then with governmental regulations, you may have heard that there's the extension of Medicaid that'll be on the ballot soon. Please, 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 in every forum that you have, in every opportunity that you have, we should be talking about this and we should be pushing for this. This is not partisan. There are people that want you to believe that this is partisan. It is not. This is all about access. And what we find in medicine, the data will show that if people that people from all walks of life will ultimately lose insurance, especially now with COVID, with people having so many layoffs, furloughs, and the unemployment rate skyrocketing right now. People need access to insurance, and we know that when states have not expanded Medicaid, albeit a lot of times it's because of money, but when they have not expanded Medicaid, those states have much worse outcomes. You can look at Texas, you can look at Missouri, and many other states that have failed to do that. Also, a prescription drug monitoring program. That was up on the ballot this summer, and unfortunately, it did not pass yet again. So we, again, are like Mississippi. We are the one state in the union that does not have a prescription drug monitoring program. Again, related to money and people thinking Big Brother is watching you and all these other things. We do know that the prescription drug monitoring program in other states has helped decrease the dispensing of narcotics because people will know when you've gotten a script from somewhere else. While it does seem like Big Brother because we're looking and finding out whether you've had a script, it also does curb the patient's ability to receive narcotics frequently from different providers. What the state has started to consider, or many I should say many systems in the state, is to just use St. Louis's prescription drug monitoring program. If everyone in the state uses the St. Louis counties, then basically we have a bootleg, if you will, prescription drug monitoring program, because we're all using that one. So I would encourage any provider who writes for prescriptions or even takes care of patients that may be on prescription narcotic medications or those restricted medications to sign up. It's free, it's easy for that prescription drug monitoring program, because if we're not able to pass it, we just all need to use St. Louis's. And then FMLA medical leave coverage is something that we need to continue to push with our politicians. We need to be asking and writing letters. Anytime there's an opportunity to go to F City, you should do so. And then focusing on maternal health. If we focus on maternal health, and I'll just kind of hang here for a second, everyone cares about the fetus and the infant. And I love my babies. I'm an OBGYN. I love the babies, right? But you can't love that baby more than you love that mom. And again, I'll quote Mama Hakima: the best place for a baby is with that mom, under every single circumstance. I don't care what she's got going. If you help mom, she can, you help her baby. If you snatch that baby, or you separate the baby so that the baby's well off and the baby's under this place and over in foster care, that's never going to be what's best for that mom. Never. What's best for the baby is to be with that mom, no matter what. So if we focus on maternal health and everything that it entails, you're going to help both. You're going to help the dyad. They are not separated. Next slide. These are the states that have Medicaid expansion in blue. It's sad that the states, as a woman of the South, it's sad that the states that have not expanded are basically largely in the South, below the Mason-Dixon line. Also, Confederate states, red states, all the above, other than Kansas, but I think they're working on it. So we need to do better. These are the states with the worst mortality for moms, other than Wyoming and South Dakota. I think their issue is money, but it's just interesting how polarizing it is. Next slide. So conclusion, sorry, I was a little bit passionate about that, but we are our sister's keeper. We are. If we just look at money, because money is the root of everything. Missouri has a negative GDP. We don't make a lot of money here. And if we just look at the numbers for this, the money that the system bleeds because of maternal mortality alone, that's loss in the mother's ability to be gainfully employed. It is a hit on the system for CHIP, for the child. Child has to be in the system, however that is determined. The child lost their own mother, so that's going to set the child up for all sorts of morbidity and consequences because its mother's no longer living, independent of the reason that the mother passed away. So if we just want to look at money and not even look at it from an altruistic standpoint, it helps us to help all of these women, every single woman. We can do better for the US. We can do better for Missouri, but every single one of us has to do our part. Any questions? I don't know if you have a way for us to do questions. Let's see.
We do have the chat box if anyone wants to put in any questions.
Okay. Oh, Mama Hakima is in here. Look at you. In our current system, yes. Yes, I love the markers too. We're going to implement that at Truman. I haven't had a chance to tell Sam and Dawn, but that was going to be my first thing next week. And that was care of Christiana Care. I'm not Christiana Care. Affinia Care in St. Louis. That's what they do. Mama Hakima says, if clients are asked to expose risk or harms, it must be into a safe environment, not a punitive, harmful, biased one. Silos maintain racist and punitive systems. Yes, they do. COVID did actually prove that telehealth worked. So yeah, I agree. we kind of revolutionized telehealth in a short amount of time because we had to. Okay, no questions, it looks like. Thank you guys so much. Oh, there's Ashley. Thank you guys so much.
Thank you, Dr. Johnson. And next we have Ashley Otto.
Hi, can you all hear me?
Yes.
Wonderful. All right. Thank you, Dr. Johnson. We've heard from lots of great speakers today. So I hope to follow this and I'll kind of try to move through a little quickly to get us on time. So my name is Ashley Otto. I work for the Department of Health and Senior Services here in Jefferson City, specifically in the Division of Community and Public Health. And today I wanted to discuss the report from the Missouri Pregnancy Associated Mortality Review that we just recently released. So in Missouri, our Maternal Mortality Review Committee is known as the PAMR board. So you'll hear me reduce it to PAMR to make it shorter. Next slide. And I have no disclosures other than my passion for women having healthy babies and pregnancies. Next slide. Okay. So for today's discussions, I wanted the participants to, be able to identify the causes and contributing factors in pregnancy-associated and pregnancy-related deaths and be able to identify at least one prevention strategy to help decrease these maternal mortalities in the futures. Next slide. And so here I just wanted to show the audience a screenshot of the cover of our report as we will discuss some of the key findings from it today. Next slide. And I know Dr. Johnson touched briefly on the definition, so I'll kind of go over this quickly. But really thinking about the different terminologies, there's lots of them kind of floating around and there's good reasons for each one of them. A death can be determined to be an instance of maternal mortality, a number of ways. So the National Center for Health Statistics and the World Health Organization, or the WHO, defines a maternal death as a death of a woman while pregnant or within 42 days of the end of pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. And so you'll see in the next slide a limitation to the use of this definition alone. So the CDC and then the American College of Obstetricians and Gynecologists, or ACOG, further expanded this definition quite a few years ago after some further research was done and they started noticing more of these deaths occurring after that 42-day mark, and really it warranted further investigation. So as you can see in the larger circle, they define the pregnancy-associated death as the death of a woman while pregnant or within that 1 year time frame, regardless of the cause. So these deaths really make up the universe of maternal mortality. And within that universe, we have, of course, the pregnancy-related, or the smaller pink bubble. And then we also have the pregnancy-associated but not related. And I'll kind of go into that in a little more detail here. So really, I just like to think of this pregnancy-associated term as really the starting point for all of our maternal mortality cases. So essentially, if you know nothing about the death other than she was pregnant or had been pregnant in that year, we classify it as a pregnancy associated because we know that she was pregnant, but we don't know yet until further review if that death is related or not. So then after the board further reviews the death, they're able to help distinguish if the death is either pregnancy associated but not related, or if it is indeed really due to that pregnancy itself. So the pregnancy associated but not related death is the death of a woman during pregnancy and within that 1 year time frame from a cause that is not related to the pregnancy. So pretty common sense there. I know Dr. Johnson gave an example. I'll also give one. So if a pregnant woman happens to die in an earthquake, so had nothing to do with that pregnancy. And you will also note from the report that many of our motor vehicle accident deaths are also categorized this way as well. Then you have the smaller portion, the pink circle here, of the pregnancy-related deaths, and those are the deaths during pregnancy or within that 1 year time frame from a pregnancy complication, a chain of events that was initiated by the pregnancy, or if one of their underlying conditions was actually aggravated by the pregnancy itself. Next slide. And so I want to just kind of show the participants how we identify our deaths here at the department. And so there's really essentially 3 methods that we use, and these are best practices from our colleagues in the Maternal Child Health Bureau and our CDC folks. And so the first way that we identify is we really investigate the death if the pregnancy checkbox on the death certificate indicated that the woman was pregnant or had been pregnant within the year preceding her death. 2, we also look to see if there's a cause of death on the death certificate that is given one of a number of ICD-10 codes indicating that the decedent died from pregnancy. And then 3, if the death certificate is linked to a birth certificate or a fetal death report from a previous year. So as you can kind of see from the different circles on here, how important it is to use all 3 methods, because if we were not able to use all 3 methods, we would really be missing cases, unfortunately. Next slide. And so while other programs are really reliant primarily on the data obtained through birth and death certificates, through the use of the PAMR board, we are able to better determine if a death is indeed due to the woman's pregnancy or if it is just a temporal association. So here's where they take a look at the relatedness. So while each death of a mother is painful, those deaths that occurred because a woman became a mother really are just particularly tragic. And so after evaluating the medical records and a variety of other reports for the cases initially identified, in 2017, we were able to exclude 10 of the cases, which yielded us 60 pregnancy-associated deaths. And so out of these deaths, the PAMR board concluded that 32% of them were pregnancy-related. And this really equates to a rate of pregnancy-related mortality in Missouri to be 26 deaths per 100,000 live births. Next slide. And so a part of the confusion that can be found when discussing maternal mortality relates to the timing of death. And so technically, anyone who dies after becoming pregnant is the death of a mother. So measuring the maternal mortality, therefore, requires not just an evaluation of the relatedness, but also a decision about when the cutoff period is. And so as previously discussed, some programs utilize a measure of within 42 days postpartum. And this is really in line with the 6-week follow-up visit, that postpartum visit, and is really often when some insurances cease coverage, as Dr. Johnson was alluding to. So however, the PAMR program evaluates deaths that occur within that 1-year time frame, and the result is not only a higher rate when looking at pregnancy-related deaths, but also a better understanding of the long-term health effects of a woman becoming pregnant. And so as you can see, the black line, vertical line, the NCHS and the WHO cutoff, if we stopped looking at those deaths that occur after 42 days postpartum, we would be missing more than 1/3 of pregnancy-related deaths. So those would have not been counted if we used that 42-day cutoff. So I just think this is kind of a profound finding here, and one of the biggest reasons why we continue to advocate for funding for these maternal mortality reviews nationally. Next slide. And so evaluating the medical records and other factors allows greater insight into the underlying cause of death in an instance of pregnancy-related maternal mortality than would be yielded solely from examining just vital statistics data alone. And so from this, the PAMR board was able to determine that the leading cause of death was cardiomyopathy, which was responsible for 26% of all pregnancy-related deaths. And you can see on the chart that the majority of these cardiomyopathy deaths occurred between that 43 days to 365 days postpartum. So think about all of those women who, going back to work, do not have insurance coverage, aren't able to come to follow-up visits, how this is affecting them. And then the second leading cause was issues with preeclampsia and eclampsia. And so I also like to point out the deaths related to mental health conditions. And so as you can see, half of those deaths occurred between 0 to 42 days postpartum, but then another half occurred between 43 to 365 days postpartum. So I always love when we're able to break down these causes with the timing of pregnancy here. And so we do like to caution that while the data being evaluated here is limited in terms of generalizability, due to very small sample sizes, these determinations do help us focus research and outreach to prevent the instances of maternal mortality in the future. And it really provides us kind of a targeted and systematic way of going about that. Next slide. And now that we briefly discussed pregnancy-related deaths, I want to really take a look at the pregnancy-associated deaths. And the majority of pregnancy-associated but not related deaths were due to accidents. And we really kind of term those as injury-related deaths. And there's kind of more of an explanation in the full report that I won't go into. And so how we do this is we really evaluate the manner of death that is listed on the death certificate for these deaths. Next slide. And so far, we really just focused on the medical kind of related deaths, so the ones that would be considered natural on a death certificate. And when we look at the non-medical or the unnatural deaths, we find the most common cause is motor vehicle accidents, as we've said before. And then this was followed by overdoses, I think the 33%, as the second leading cause of unnatural deaths. And so I want to break this down a little bit further and really look at the timing of these deaths, which I think really can provide valuable information when looking at prevention opportunities and resource availability. Next slide. And so, as you can see from this slide, the majority of overdose deaths were found to occur between that 43 days and 1 year postpartum, again, when insurance coverage ceases. Overdoses made up almost half of all deaths that occurred during this time period, the 43 days to 1 year. And so then the majority of motor vehicle accidents occurred also between that same time period. 67% of them occurred between 43 days and 1 year, while 33% occurred during pregnancy. And so what we just found really striking, and I just want to reiterate what Dr. Johnson was saying, is that 85% of these motor vehicle accidents, the decedent was unrestrained. So what can we do to help these individuals? What are the barriers, or what are beliefs behind wearing seatbelts? Those are kind of some of the more qualitative data that we would like to capture in order to effectively have some, educational campaign to where we are really targeting those and trying to break down those barriers. And so another thing I want to point out too is the majority of homicides, you can see there on the bottom, 78% of them occurred during that pregnant time frame, okay? And then while another 22% occurred in that postpartum period, the 43 days to 1 year. And so homicides comprised almost 60% of all of the injury-related deaths occurring during that pregnant period. Next slide. And so, as many of you know, there are profound disparities in maternal mortality. And I just want to take a look at what we found for Missouri. So the racial disparities in outcomes, specifically for African American women, is striking. And what is interesting when we broke this down is that, sorry, I think can you go back one more slide? I think I missed. Oh, there's one missing. Sorry. So let me just discuss this slide, and then I'll kind of go into talking about the injury-related deaths here. Maybe move forward one more, please. Okay. So I'm missing a pie chart slide in here, but really, so you'll be able to see it in the report. And I just think it's so interesting because when you look at it, our analyst really pulled the percentage of Missouri live births by race and ethnicity. And what we, oh, here we go. Yes, thank you. Sorry, I must have had them out of order. When you look at that first pie chart to the left, you can see that the majority of live births in 2017, 75% were to non-Hispanic white women. The smaller portion, the pink piece of it, the 15% was to non-Hispanic Black women. But then if you look at the pie charts to the right, you can just see how that shift is in the disparities. So you can see, even though there are 15% of births to Black mothers, they make up 40% of pregnancy-associated deaths and 32% of pregnancy-related deaths. So what this really essentially equates to, when you look down at the pie chart to the right, is the pregnancy-related mortality ratio for Black mothers in Missouri equates to 53.3 deaths per 100,000 live births. And that's compared to 21.9 deaths per 100,000 live births for white mothers. And so you can just, see such a notable disproportion when viewing these on the same slide. So now can you go to the slide that says disparities continued? It's the injury related. There we go. Thank you. And so this slide here provides a little bit more insight into the disparities identified for our pregnancy-associated deaths that are considered unnatural or, as we term, injury-related. And so, as noted previously, while 15% of live births were to Black Missouri mothers, in 2017, they made up 50% of homicide, 38% of overdose, and 37% of motor vehicle accident deaths. I just want to pause for a moment to kind of let that sink in. Okay, next slide, please. Thank you. And so beyond the underlying cause of death, there are a number of factors that we look at. The PAMR board considers 3 of these factors specifically: mental health conditions, substance use, and obesity. The influence of mental health conditions played a role in 16% of pregnancy-related deaths and nearly 30% of pregnancy-associated but not related deaths. Then while substance use played a role in 16% of pregnancy-related deaths, it was a factor in 44% of pregnancy-associated but not related deaths. And while obesity really was not a factor at work for the pregnancy-associated deaths, Obesity had a role in 21% of the pregnancy-related deaths and was a likely contributor to another 16% of them. Next slide. So in addition to determining if a death was directly related to pregnancy or not, and evaluating the death causes and contributing factors, the PAMR board also evaluates if a pregnancy-related death was preventable or not. And so the board found that there was a good chance to prevent nearly half of these deaths, and that another third of them had at least some chance to have been prevented. And so really for purposes of analysis, we combine these two categories, which equates out to 80% of pregnancy-related deaths being preventable. And that so many of these deaths may have been prevented, it may seem disheartening, but really it's an indication that the goal of reducing maternal mortality is indeed achievable. Next slide. And so the PAMR board is then tasked with recommending practices or changes that if implemented could improve maternal mortality in our state. Next slide. And so these recommendations are targeted to persons or groups in order to be most effective. And that's how we look at these category levels here. The bulk of board recommendations, so 40%, were targeted at issues that the patient or family could address. On the other hand, provider level recommendations made up 33% of the recommendations. And so while the majority of the identified opportunities for prevention were categorized as patient or family, these often interacted with other categories. So this is detailed further in the report, and I would really encourage participants to read this section, because I think sometimes just looking at this slide, it can be slightly misleading with all the recommendations being put at the patient or family level. So in addition to identifying themes using the category and classification, content analysis was performed on the recommendations to supplement these quantitative measures with a little bit more qualitative data. There were basically 4 dominant themes which emerged through this process to really help target efforts at decreasing maternal mortality. The most prominent theme were recommendations for standardization, and I know Dr. Johnson talked a little bit about this. This was really followed by themes focused on enhancing education for both patients and providers, and additionally the board recommended increasing services and knowledge for the treatment of mental health issues and substance use disorder. For example, themes emerged on increasing patient education regarding the dangers and treatment options for substance use disorders. But the committee also recommended providers standardized screening, standardized prescription, and also treatment practices. So based upon the content analysis, opportunities for prevention of this issue exist across multiple categories. And so this is really the kind of supplementary data that requires qualitative analysis to obtain. Next slide. And so we look at the recommendation the recommendation impact level in order to be able to prioritize the recommendations. So not shown in the data here regarding the impact level is really the cumulative effect that small impacts can eventually have when shared. And really our analyst pinpointed this as, these tend to work more at the person-to-person level, but as we've all experienced recently with the COVID pandemic going on, is that something that is shared from one person to another can quickly result in a much larger yield than might initially be expected. So while 84% of the recommendations were small to medium, that doesn't mean we have to start shooting for only the ones that will have an extra large or a giant impact. Next slide. And so now I want to really pull out those key recommendations that came from our PAMR board. And so we aim to have SMART recommendations. And just in case you're not familiar with this acronym, it stands for specific, measurable, achievable, relevant, and time-bound. And so the key recommendations are as follow: standardized practices and procedures across the healthcare system through utilization of evidence-based practices and such as AIM bundles. That's just an example, but really standardization overall needs to occur. Healthcare systems should increase continuity of care for women in regards to referrals, follow-up care, communication, social determinants of health, transfer of care. Anything that those barriers are inhibiting a woman from being at her healthiest during pregnancy and in that postpartum period. And then all providers, no matter who that woman sees, not just the OBs, all providers should perform validated depression and or anxiety and substance use screenings at multiple intervals throughout pregnancy and the postpartum period, and then make referrals to the providers as appropriate. And then again, the state should increase public awareness of the importance of seatbelt safety during the perinatal period. And we're really working internally on a campaign. So again, we would really like any additional feedback on you know, patient perceptions on using seatbelt during pregnancies or even the postpartum period or barriers to that. Next slide. And then providers should be further educated regarding screening, referral, and treatment of mental health conditions, substance use disorder, cardiovascular disorders associated with pregnancy. And so I know Dr. Florio and Dr. Johnson are really working with our MC LAN and other avenues throughout the state to really provide that basis for this education. And then the state should extend Medicaid coverage to 1 year postpartum for all conditions, including medical, mental health, and substance use disorder, even if the woman did not start treatment prior to delivery, because we want to ensure that the women whose condition is exacerbated in that postpartum period. So when you think back to those slides where the majority of overdoses are occurring after that 42-day cutoff. And you know, the cardiovascular issues occurring 6 months after delivery. Those are really the women that we really need to help more. And then it really expand community outreach to educate women on preconception health, to optimize a woman's health regarding, we wanted to try to cover an array of things. So obesity, tobacco use, chronic medical conditions, in those vulnerable populations to really address these disparities in health outcomes. Next slide. And so I kind of just have a little mock case study here, which I know Dr. Florio kind of had one, but really I wanted to kind of give the participants a chance to experience kind of a maternal mortality review firsthand. So I will try to quickly read this because I know we're a little behind. So, and again, this is a mock case study, so it's really pooled information and a little fictitious, but it's generally kind of some of the things that we just see on a recurrent basis. So the decedent is a 20-year-old gravida 2, para 2, living 2, biracial female with a high school education who works as a nurse's aide, has Medicaid for insurance, and has never been married. Her family history consists of cancer, hypertension, heart disease, and seizures. Her medical history consists of asthma, anxiety, and obesity. She is a smoker but denies alcohol and drug use. Her obstetric history consists of a preterm cesarean birth due to severe preeclampsia. She initiated prenatal care for the second pregnancy in the second trimester with 5 total visits. It was noted she wasn't able to get off work. At her first visit, which was around 19 weeks, she was counseled on smoking cessation and received an ultrasound, which revealed possible hydronephrosis, and she was referred to a maternal fetal medicine specialist. These records were unfortunately not able to be received, which happens in a lot of our cases because it's not always documented where the follow-up happens. So this patient was delivered by a repeat C-section at 38 and 2 for elevated blood pressures. 1 day after delivery, she developed a dry cough. Her chest x-ray was negative. A social service consult was completed for her limited prenatal care. She was discharged home on day number 3 to follow up with her OB in 1 week and then again in 2 weeks. At her 1-week follow-up, she complained of being tired and still having pain. Edema was noted in her lower extremities. She was encouraged to ambulate more and quit smoking. She was advised to continue with Motrin every 6 hours for pain and to call if pain does not get better. 2 days later, she presented to the emergency department, same as the delivering facility, with complaints of chest pain and shortness of breath times 2 hours. Her studies were negative for pulmonary embolus. Her chest x-ray and computed tomography or CT scan was noted cardiomegaly consistent with postpartum state. Her EKG was noted as sinus tachycardia. Her pain was relieved with narcotics, and she was discharged home with instructions to follow up with her primary care physician. 3 weeks later, she presented to a different emergency room complaining of shortness of breath and chest pain. She was diagnosed with an NSTEMI and cardiogenic shock and admitted to the ICU. 7 hours after admission, she was transferred out to a higher level of cardiac care. A cardiac cath was completed, cardiac support was given, but she eventually died 7 days later. So this is just kind of an example of the information that is provided to our board of expertise. And so really you can kind of look back into this example here, and I kind of call that first discharge from the emergency room as really the point of no return. But then again, you know, there's just many things of ways that we can help support these women a little bit better than what we are doing now. And so next slide. So in conclusion, we are doing the necessary work of identifying and understanding the problem today so that we no longer have a problem tomorrow. So I really want to, next slide, please. I really want to thank our PAMR board members and especially our staff who has worked so hard to really put this report together. I would also like to thank Nurture KC for inviting me to present today and for their dedication to improving the health of moms and families. We will, our PAMR board is almost finished reviewing 2018 maternal mortalities. And so we will be working on that report as well. And the good thing about this is that we will then have 2 years of data to combine, which I feel will you know, provide a little bit more rich understanding into some of these data points that we had to unfortunately retract just because of the small numbers. Because of course, you know, we have to ensure that we're maintaining confidentiality. So again, this is my contact information. I hope that you all have at some point been sent the report. We've been sending it out electronically. If not, you can visit health.mo.gov, and we have a maternal mortality review page that has our report on there. And if you have any trouble at all, feel free to contact me, and I can get that report sent to you. Thank you.
Thanks, Ashley. Before we get to Mary Ann, who is our last speaker today, I just want to let everyone know that in the interest of time, if you have questions for any of the speakers, please go ahead and start putting those in the chat box. If you want to direct it to a particular person, please let me know that as well. And we will still do our best to stay within the time limit that we have established, but I want to make sure that we're able to get all questions answered one way or another. If not live today, we will certainly share those with our panelists and make sure that you get your question answered. There have been several requests for various presentations and reports. We will also circle back on those and see what we can do to get those distributed as well after the meeting. With that, we will go to Mary Ann Lytle. Thank you. Mary Ann, are you on?
I see you, but I don't hear you.
I think you can be muted.
Can you hear me now?
We can.
Hello? Can you hear me?
We can hear you.
Oh, okay. Sorry about that.
Thank you.
So thank you for having me. I appreciate it. I can get on board with what Dr. Tracy Johnson said in the beginning. Well, not in the beginning, but in part of her slide where she said, you can't love that baby more than you love the mama. I'm super passionate about mama's mental health. So I just put together a quick overview of postpartum depression and how we can kind of make a better impact with our mamas. What I did note when I was putting this together is that their research has come a long way in regards to postpartum depression, but there's still, it just lacks focus on women of color, and it still lacks focus on those minority women, Latina, Hispanic culture as well. So some of my information may not quite hip on that, but I feel like part of that is because of the lack of research that I've noticed. So if you just want to start the slide, Shannon. So sometimes I always explain this to my mom as postpartum depression versus baby blues, and sometimes people don't really understand the difference. So baby blues, almost 80% of women who deliver a child experience baby blues, and that is going to happen in those first couple of weeks after delivery. And they're going to subside without any treatment. And those symptoms can range from like just being super anxious to, crying because you dropped the wash rag, crying because you put the diaper on backwards, just things that when those hormones are up and down really kind of tip you over the edge. But then again, like I said, it subsides, and those symptoms subside without any form of treatment, without any intervention. Because postpartum depression is so severe, it often requires treatment. So next slide. Another thing that people think is, oh, well, I'm not going to get postpartum depression because I'm not going to drown my baby. And so sometimes I have to remind the mamas here too that like the risk of postpartum psychosis is very low. It's a low prevalence. So 1 to 2 out of every 1,000 deliveries. However, those are the ones that the media runs with, right? So those are the ones that we're going to see frequently. But they don't depict a full picture of what postpartum depression really looks like. And this onset is usually pretty sudden and within the first 2 weeks. Like delusions, strange beliefs, seeing or hearing things that aren't there, hyperactivity, decreased ability or need for sleep, paranoia, rapid mood swings, like difficulty communicating. What I really try to hit home is like, if mama is not reality based, then maybe we need to, have her checked out. And I really kind of also
speak directly to the dads when I'm in the room doing assessments as well, because I feel like they're very much a part of what this new life is bringing into the world, and a part of the postpartum period as well. So next slide. Startling statistics. So it's just kind of really astronomical to me that 1 in 7 women who deliver a child will be diagnosed with postpartum depression. What I did find was that postpartum depression prevalence between white mamas and our Black mamas is very similar in prevalence, but the screening is where we have great disparities, right? We have communication barriers in there, and then we also have our Black mamas are more likely to report that they're feeling physical symptoms versus mental health symptoms that we often think about. So like less saying that I'm anxious or I'm feeling irritated, and more of I'm fatigued, I've had a headache, I need a lot of sleep, those types of things. And those symptoms are easily dismissed as, well, you're a new mom, so of course you're tired, right? And I just put, in a world that still doesn't understand the notion that mental health matters in general, that can be a dangerous problem when we apply that theory or that mindset and thinking to our postpartum mamas. So next slide. So I did look up, so Missouri and Kansas is pretty similar. In 2019, the postpartum depression rate was 13.9 in Missouri and 12.5 in the state of Kansas. Missouri is a little bit higher than the national average of the 12.5. The lowest state is Iowa with a 7.4. For this particular presentation, I did not delve deeper into why Iowa is so low. Based on my recommendations and what I know and my trainings that I've experienced, I would assume that it's because they are screening really well, and they're implementing the appropriate remedies or support for these moms. So next slide. Okay, so what is going to make a mom more at risk for postpartum depression? It's going to be a kind of a myriad of things, but her personal and family health is going to be a factor. If she's had symptoms during pregnancy, so some moms you may hear say, well, I had postpartum depression during pregnancy, and that's a perinatal mood disorder. And so having that while she's pregnant is going to definitely impact her risk for having the postpartum depression after pregnancy. A history of depression, so like just in general, her mental health, where is her mental health prior to pregnancy? Does she have anxiety, bipolar disorder, eating disorder, OCD? Those are the main ones that you definitely want to be aware of. If she had trouble in puberty or like significant mood swings, that's going to be another risk factor. Thyroid disorders and infertility. Obviously, infertility there is associated with that. You're going to have probably some anxiety in there, and then also some trauma and grief is going to likely be associated with that as well. So next slide. Risk factors, inadequate social support, IPV, interpersonal violence, or being exposed to violence in childhood trauma. I know a couple of our presenters today have touched on that as well. Financial stress, low socioeconomic status, which I feel like is a lot of the moms that I'm serving are on Medicaid, and I wholeheartedly agree that Medicaid needs to be expanded because that would, I think, make a huge impact. I'm often finding myself reminding them, now your Medicaid is going to expire now, at this time period. So I'm really going to don't forget to, do your follow-up, address any problems or needs that you're having with your OB. And just because you have an appointment at 6 weeks, if you're having problems before that 6 weeks, you need to, make contact. Another thing is high stress parenting situations. Examples can be military families, teen parents, moms of multiples, close interconceptual spacing. So, or you see those mamas that have had, have 3 kids under 3. The other thing is being a single parent. That's a high stress parenting situation because sometimes that can also come with, the IPV as well. Another thing that I found that's not listed on my slide here, just our Black mamas in and of themselves are just at a higher risk because a lot of the times they don't have enough social support. They're limited access to medical care, single parenthood. Those things are going to increase stress, and which we know stress increases our risk for a perinatal or a postpartum depression. Next slide. So what can we do about it? Well, we can screen. And I kind of, as I was preparing this, kind of found myself saying, okay, who are we going to screen? What are we going to use? When are we going to do it? So I kind of broke it down that way. Anybody who is meeting with childbearing families should probably be screening. So WIC, parenting classes, lactation consultants. I know that there's a lot of pressure put on pediatricians and OB providers to screen as well, but sometimes these other community supports are meeting or seeing these moms more frequently or have a better relationship with these moms. So one thing that we find, especially with mental health and especially with our Black mamas, there's a specific style of communication and there's a specific level of trust that comes with that relationship. And sometimes when you are in that provider role, as in like a physician or a pediatrician, if you don't have the ability to communicate with that mom in the way that she feels that she can trust you, she's not going to answer truthfully. So sometimes these other agencies are a little more appropriate if you are. It kind of sounds funny to say it, but that is truthfully, I feel like, is why that can be a better option. Pregnant and postpartum women are who should be screened. And I've heard a lot of this said already, but postpartum does not end at the 6-week OB checkup. Like we don't get off the train right there, I guess. And who gives us our recommendation? So the American Academy of Pediatrics, ACOG, Postpartum Support International, I've done a lot of training through them and they have great recommendations as well. The next slide, please. So what are we going to use to screen? I see somebody just made a comment about the EPDS. So there are several screening tools. Like you can use the PHQ-9, you can use the PASS, which is a perinatal anxiety screening. But some of those have costs associated with them or specific training, which, as we know, if we go back to the previous slide when I talked about WIC and those other agencies that could be screening these moms, it might be not cost effective, obviously, because that's always a problem, right? But the EPDS is the Edinburgh Postpartum Depression Scale, and that is the most validated. It's free, so it's cost effective. It's available in different languages, and it's validated in different languages, and it's easy to administer and to score. It's 10 questions. It's pretty cut and dry. So I feel like the EPDS kind of captures what we need to capture for those postpartum women. And this can also be used prior to delivery as well. Next slide. When are we going to screen? So everybody has an opinion here, if you will. The American Academy of Pediatrics is saying that we need to implement the postpartum depression screening at the 1, 2, 4, and 6 month well-child visits. ACOG says once during the prenatal period and once during the comprehensive postpartum visit. Postpartum Support International says let's do it all, basically. The first prenatal visit, which I feel like is appropriate because that gives us a baseline, so you're kind of able to compare. And then once in the second trimester, once in the third trimester. And I feel like that can be validated by any moms that are on here listening. There's a big difference of how you feel in the second trimester versus the third trimester. Things can get more stressful. Delivery is obviously a lot closer. You're trying to rush around and get things ready. If it's not your first child, you're caring for other children as well. That can be more taxing. That's when we kind of see more of those preeclampsia mamas and stuff. So things can just be more stressful in that third trimester. The 6-week postpartum OB visit or the first OB visit is appropriate. And then repeated screenings at the 6 and 12 month mark in OB and primary care settings. And then for the babies, Postpartum Support International says let's do it at the 6-week checkup, the 3, 9, and then 12-month pediatric visit. So if you're looking at all of those recommendations, it's basically all the time. Lots of suggestions and all the time. We know that moms have barriers to often have barriers in regards to caring for themselves, but somehow those mamas are often still taking their baby to the doctor. So I feel like people who are connected when it comes to pediatric care are critical in making sure that they provide those screenings. And what do we do if there's a positive score? So we're going to refer to a mental health professional that focuses in PPD or a mental health provider. And those should also be culturally and racially appropriate as well, because there are things that can be addressed in that manner that may create a barrier again to having a successful experience or have successful treatment of PPD if we're not making sure that we're being culturally appropriate there. Next slide. So what about the babies? Postpartum maternal depression is associated with increased risk of physical health problems and general medical illnesses for kiddos. Asthma, colic, diabetes, or diarrhea. The other thing we're going to see is postnatal depression appears to be associated with difficult temperament and sleeping problems in the infant. I know sometimes here on the floor, I definitely hear the nurses say, baby can feel your anxiety, just try to rest. We'll take the baby to the nursery for a little bit. So having good coping skills, I feel like is huge because you pass on those coping skills to those babies. Emotional and behavioral problems as well as impaired motor functioning. And I know that sometimes we don't think of when we have emotional and behavioral problems in, let's say, a 3 to 5-year-old, we're not thinking like, oh, I wonder if his mom had postpartum depression. That's not usually the first thing that comes to mind. So I felt like that was pretty interesting. Long-term effects on children can include like cognitive impairment, executive functioning, next yeah, there we go. Sorry. And like, obviously, the longer the episode of PPD, the poorer the outcome, right? So the longer the child is not purposefully neglected, but just doesn't have that loving bond with that mom, and may not be tended to like a baby who has a mama that is not experiencing that, the poorer the outcome, right? She's not going to be interacting and talking and playing with the baby quite as much if she can't bring herself to get out of bed, or if she has a headache, those types of things. Her tolerance for the baby's needs or complaints are going to be less, right? Okay, and then just in conclusion, I just feel like we really have a responsibility to screen moms that we're working with. We have a responsibility to them and their children. Their children grow up to be parents of the next generation, and we already know that postpartum depression has a huge impact on the moms we serve. So obviously, as more research becomes available, we have even a greater responsibility. We have to just bridge the gap. The more mindful that we are of the cultural differences that exist among the women we serve, the better we can serve them as well. Because what works for one mom is definitely not going to work for another. You're going to have to meet those mamas where they are. And obviously, like I have this quote here, it says that the long-term detrimental consequences for the mother-child relationship extends well beyond adolescence. So that right there highlights the need for the investment in strategies to prevent PPD. And I feel like those of us who are making contact with these moms who are pregnant and postpartum owe it to the kiddos and to the mamas for sure. So
Thanks so much, Marianne.
thank you.
If there are any questions, we will certainly deliver those to our presenters. And because we are right at time, I think I'm going to go ahead and turn it over to Stephanie Seeger for our conclusion and a call to action. And thanks so much for everybody who's attended today and for our presenters.
Thanks, Tracy. I just thank you again to the presenters, and thank you all for being here today. I hope you found the presentation as inspiring and as informative as I did, and I really feel like together we can work together to reduce maternal mortality and improve birth outcomes for all women, but especially Black women. And I think, you know, we're ready to create impactful change after meetings like this. So as Tracy said, now it's time for the call to action. So what must we do? We must expand Medicaid. According to the World Health Organization, you can see the statistic there. Women without health insurance are 3 to 4 times more likely to die of pregnancy complication than those who are uninsured. The uninsured rate for women of childbearing age is nearly double in non-expansion states like Kansas and Missouri, and 16% versus 9%. We can make Missouri the 38th state to expand Medicaid eligibility. How do we do that? We endorse ballot initiative number 2 as an organization. We go out and vote on August the 4th. And if you'd like more information on this initiative, you can go to www.healthcareformissouri.org. You can support legislation to expand Medicaid in Kansas that would improve access to healthcare for all Kansans. And to do that, please visit www.expandcancare.com. We could go to the next slide, please. The next thing we need to do is recognize that racism is a public health issue and needs our immediate attention. To do this, we need to create policies and procedures with an explicit focus on equity, collect data to track and monitor racial disparities in birth outcomes, use evidence-based strategies supported by data to reduce disparities in birth outcomes, and listen to and advocate for and empower Black women in birth settings. Next slide, please. Lastly, we'd invite you to join us to do this work by becoming a member of Nurture KC. Membership benefits include networking and professional development, invitations to Nurture KC meetings, opportunities to participate on standing and program committees, access to resources through our website, internship and volunteer opportunities, quarterly mailings, including our newsletter subscription, email, broadcasts, and social media updates. Next slide, please. You can become a member at the individual level or join as an organization. Stay tuned for updated membership benefits in the near future. And to find out more, please visit the website that Shannon shared earlier, www.nurturekc.org. And again, thank you all for attending today's meeting and for sticking with us. I know we're running up on time here. We hope you enjoyed this very important meeting and learning about this very important work. Please remember to complete the evaluation survey for today's meeting. You can use the QR code or the link that has been added to the chat box. It doesn't look like yet, but it will be. Until next time, everyone stay safe and healthy and well.
Well, it's not letting me access the chat box. So what I will do, I will send the email link to everyone of the attendees today, along with the QR code, so that you have both options. With the QR code, you can just use your cell phone if you like, take a picture and it'll take you right to the website, or you can copy and paste the link and take you right to the website. Nurses that are getting CE credits, you have until August 5th to complete the survey and be able to print off your certificate for CEs. Everyone else will get a certificate of attendance from Nurture KC. Again, thank you. We appreciate you attending. Thank you to all the presenters for the great meeting today, and we hope that you have a wonderful weekend.